Good morning, everybody. Welcome to the 50th Annual Academic Sessions of College of Surgeons of Sri Lanka, held in collaboration with the Royal College of Surgeons of Edinburgh and the SARC Surgical Care Society. We will be starting today's proceedings with the Meet the Expert session on techniques and tips of Hepaticogenostomy in Hall A. Dr. Buddhika Dasanayaka and Dr. Duminda Subasinghe will be joining us virtually to answer your questions. And Hall B is the council room, and we have experts on cardiac surgery covering mitral valve repair and surgery of the root of the aorta in Hall B. Dr. Ajit Karunaratne and Dr. K. Yanakanthan will answer your questions on these topics in Hall B. Over to you, Dr. Dasanayak and Dr. Subasinghe.
So very early morning to all of you all. I know it's very early, bit too early, I suppose, for all those who have enjoyed yesterday's fellowship. So welcome to the first day of sessions of College of Surgeons of Sri Lanka 2021. First of all, I would like to thank the Council of College of Surgeons 2021 for offering the Sri Lanka HPBA to conduct breakfast sessions. And this will be 3 consecutive discussions on key components of HPB surgery, where it is equally important to all the surgeons in general, as well as for all the HPB trainees. So today we have 2 eminent young surgeons, all fresh, just coming back from training in UK, with loads of knowledge on their back to discuss about the hepaticogenostomy. This, as you all know, is a very important area for general surgeons as well as HPV surgeons, as I mentioned earlier. This technique, it is a technique that all the young and old should have in their armor, especially when you're dealing with HPV cases. I will just let you know the bad consequences of a failed HPV or complicated hepaticogenostomy that can result to a patient, right? Because how to do it properly, these 2 guys will tell you. If you get it wrong, the life will be miserable for this patient, right? You know, his quality of life will drastically drop. They will be in and out of the hospital, multiple hospital admissions. Patients will be suffering from phalangitis. They will have secondary stone formations, strictures at that place, multiple abscesses, right? He will undergo various interventions, multiple ERCPs, stenting attempts, right? Dilatations, sepsis, EBDs, right? You name it, they will all have it, and ultimately may sometimes end up with transplant as well. So that is why we should do it once, and should do it once with the correct technique for a sound anastomosis, right? So these 2 young surgeons will discuss, give you some tips and how to do it. And for the trainees, I think it's all the slides are really important, but for people who are doing it at the moment, they are telling you some of the tips that they have learned in the training. You can ask questions at the end of the session, right? Or you can post your questions on the chat box where we will be discussing. And of course, I'm also going to question them on certain things that, you know, doubtful things that I have with these 2 guys who are coming back with new knowledge. So it's good, Duminda and Buddhika. So Duminda, a short say about Duminda, everybody knows who Duminda is. Like he graduated, entered the program as MD trainee in 2012, got his MD in 2015, he had obtained his MRCS in 2016. He was trained in one of the top centers in Sri Lanka, National Hospital Colombo in the Prof unit, and then he joined the South Colombo Teaching Hospital, where they do a lot of HPV work. Then he joined the Department of Surgery, University of Colombo in 2016 as a lecturer. During his overseas training, he did his MD training in GI and HPV surgery. He worked as a senior clinical fellow in hepatobiliary pancreatic surgery at IMT Liverpool. and as a specialist registrar in HPV surgery and liver transplantation at Queen Elizabeth Hospital, Birmingham. That's number one place where they do like the most number of transplants and very complex HPV cases. And a senior clinical fellow in HPV surgery at Bristol Royal Infirmary, right? And as you all know, he's very bright student. He has obtained, he has done many publications. He has got National Research Council Merit Awards. He has got PR Anthony Research Award in 2017, 2018 from College of Surgeons of Sri Lanka. I think he has got presidential awards in 2014 for one of his research, and many more. I go on, there are many more. His research interests are hepatopancreatic surgery, gastrointestinal cancers, colorectal metastasis, and acute. So that's about Duminder. Can I just briefly tell about Buddhika as well? He's my colleague. We are working together. So he obtained his MD in 2014, MRCS in 2014 again. Then he obtained fellowship from India for minimal access surgery in 2017. So his key interest is hepatobiliary surgery, right? He was trained at Birmingham for 2 years, and especially in hepatobiliary and transplant, and especially in pediatric transplant. And I must say, his disease is the main highlight is he managed to do a pediatric transplant at Teaching Hospital Peradeniya very recently with a very successful outcome. And then he was involved in Birmingham in Naples program where they try to salvage marginal liver grafts of patients. So he was a founder member on that Naples program. He came back to Sri Lanka in 2020, then started doing all HPV complex cases here at Peradeniya. So that's about all he has given, but he's a very bright chap. He has done many publications and research. So I will hand this podium to them to take you all through hepaticogestomy. So towards the end, we will ask questions. Registrars, you all can post questions on the chat box, which we will try to answer questions. But anyway, I'll hand over the podium to, I think, Duminder will start the discussion. Over to you, Duminder.
Thank you very much, sir, for those kind words of introduction. Good morning, everybody. The hepaticogestomy anastomosis, it is a method of re-establishing biliary enteric continuation following major surgical procedures. Especially, it's an important step in pancreatic resections, major liver resections, as well as the transplant procedures. So basically, it's a procedure involving reconstruction following various benign as well as malignant conditions. So, but if you look at the basic techniques, it's as for any anastomosis, all the general principles will apply here. The tension-free with good blood supply, the both ends, and the disease-free ends. So the basic principles are same. But there are some peculiar specific features relevant here. So it's like a single layer anastomosis, which is performed using absorbable monofilament sutures to prevent the cut through the bile duct with 4/5 sutures. And also, I must mention that it's a good surgical practice to do these procedures under loops, the surgical magnification, because as mentioned earlier, you have only one chance here. Because the failure of this critical anastomosis can lead to significant morbidity as well as mortality. Therefore, the precise technique and the meticulous technique is very much important. But if you look at the basic principles of blood supply of the bile duct, this diagram shows the blood supply of the bile duct. You can see from the top end of the bile duct near the hilum, your right hepatic artery goes behind the bile duct, which is the main supply in the top area. If you look at the bottom part of the bile duct, the main supply is from the gastroduodenal artery. Although it has been conventionally described, there is an arterial plexus all around the bile duct. To really concentrate this middle area, which is the watershed area, which are more prone to get ischemic strictures if you perform this anastomosis in that particular area. So that's the reason we do high anastomosis with hepaticogestomy. So as for any operation, this operation also can be divided into key steps. So division and preparation of the extrahepatic bile duct from the top end. And then from the bottom end, you need to bring up a rulu. So the preparation of the rulu and the preparation of the bile duct and the basic anastomotic procedure. The anastomosis again involves two layers, the two walls, anterior and posterior. Buddhika, you will talk about the preparation of the bile duct. Over to you.
Buddhika, you are muted, Buddhika. Buddhika, you are muted.
Yeah, thank you. Thank you again, Dr. Arinder and Dr. Duminder. First, we'll be talking about preparation of the bile ducting, then progressing on to preparation of the rulu, which Duminder will be talking about. So, the bile duct, especially at the hilum, is not an easily accessible place. So the first thing that one would need to do is to make the bile duct more accessible at the hilum. So an important step is to lower the liver and retract up on segment 4 so that the bile duct is as accessible as possible at the hilum. Following this, we would also need to divide the hilar plate, which we'll be talking about next. It's very important to remember that the right hepatic artery is at risk when taking stitches from the posterior side. So it's always good practice to keep the posterior edge of the duct a little longer than the anterior edge. We sometimes widen the duct orifice by doing an extension called the Hepconod extension, which I'll be talking about next. And lastly, we need to also know how to deal with bleeders from the duct edge. Next slide, please. Thanks. So in the supine position, when we make our transverse upper abdominal incision or a reverse L incision, we find that the hilum of the liver is facing downwards and not really accessible to us. So we have to do two things to make this hilum accessible in the first place. First, we must pack a towel underneath the dome of the diaphragm to push the liver downwards. And next slide, please. Along with that, we have to also place a retractor on segment 4 and lift up and outwards. This combined procedure allows us access to the hilum and makes the surgery a bit easier, because otherwise we might actually be stretching inside the costal margin and digging somewhere deep. So this maneuver is quite important to get access. Next slide, please. So there are 3 plates or 3 peritoneal reflections which adhere to the parenchyma of the liver close to the hilum. The first is the cystic plate, which is in the gallbladder region. The next one is the hilar plate, and the third one is the umbilical plate. So the common hepatic duct is hidden under the hilar plate until the hilar plate is divided. The common hepatic duct, which you can see in green on the right side, is not visible. Previous slide, please. Thanks. So when the hilar plate is divided, it makes the common hepatic duct accessible. And you will also notice that the left hepatic duct has a long extrahepatic course, which is quite useful when we want to widen the orifice for an easier anastomosis. Next slide, please. So an important thing to remember is that the right hepatic artery is situated just underneath the common hepatic duct, pretty much at the confluence between the left and right hepatic ducts. And that is why if the posterior edge of the cut bile duct is short, our stitches might damage the right hepatic artery. And that's why I mentioned that keeping the posterior edge of the bile duct a little longer than the anterior edge helps with avoiding damage to the right hepatic artery at this point. Next slide, please. So this is the hip cunod extension that I mentioned earlier. If the common orifice is very narrow, or if we have gone so high up that we have actually come to the carina as such of the confluence of the right and left hepatic ducts, we might be able to achieve a wide anastomosis by extending our incision longitudinally along the extrahepatic course of the left hepatic duct. And that makes the anastomosis a bit easier. At the same time, the little dots that you see on the upper part of the bile duct, the gray dots, are blood vessels. And you will notice that if you have good vascularity at the edge and if you have made a clean cut, all these vessels will bleed. Sometimes there will be spurting bleeders there. Now, this is troublesome. It reduces visibility and it can make for an insecure anastomosis if we don't take the stitches in the correct places. The problem is that we should never deal with these bleeders with rough techniques like monopolar diatony. The best technique would be to pick the point of the bleeding and just stitch that bleed with a 6-0 suture. And remember, you have to cut those stitches very short. If not, they can interfere with the subsequent sutures you put on the anastomosis. So directly stitching off the bleeders with a fine suture is the best technique. But to obtain visibility in order to place those stitches, you would probably have to do a lot of washing. An olive tip cannula can be used to irrigate the region when it's done. You can see an image up above. If not, a plastic disposable cannula connected to syringe can also be used. So while the assistant is washing away the bleeding, the operator can place those fine targeted sutures. And also at this point, it's good practice to change from your Yankee sucker or from the pool sucker that is being used in the general operative field to a fine Frazier sucker so that we can just suck just on a point instead of blindly sucking that whole area. Next slide, please. So over to you, Duminder, to discuss the next step, which is preparation of the bowel.
So once you prepare the bile duct from the top end in the supracolic compartment, next important step is to prepare the roux loop. So how do you do that? So you need to lift the transverse colon up and to identify the DJ flexion. Then you have to bring a loop of jejunum, the first loop of jejunum, which will reach without a tension to the bile duct end. So how you do it? You take that loop over the transverse colon. So if it reaches anticolic way, it will anyway reach through the retrocolic route without any problem, without any causing any tension. So that point, if you identified that point, then you need to divide the bowel with staplers. And always it's good to suture these bowel lengths with, again, trio monofilament suture in purpose of hemostasis. Then if you concentrate on this diagram, towards the right side of the middle colic artery, there's an avascular window in the transverse mesocolon. So you need to make an incision there. And if there's a feeding vessel, you need to tie that very meticulously. Then bring your roux loop up. So usually at this point, it's the length from the DJ flexure is about 25 to 30 centimeters. That depends. But the important point here is from your top end of the anastomosis, your hepaticogenostomy, which will happen here. And there should be another anastomosis to achieve the enteric continuity, which is usually side to side jejunogenostomy. There should be at least 40 centimeters from top anastomosis to here to prevent the bile reflux and to mitigate future cholangitis. So length of minimum 40 centimeters is important point here. Then again, side to side jejunostomy is the one which is commonly practiced. It's a hands-on anastomosis. So once you bring the roux loop up, next step is to put a enterotomy. So where to put this enterotomy? It should be about 3 to 5 centimeters from the blind end, the sutured blind end from the jejunal loop, at anti-mesenteric border. So that is the exact place. Especially if you are doing this reconstruction in the setup of a repulse pancreatic or duodenectomy, especially about 5 centimeter distance is important. Then how wide should be the enterotomy? So always it should be lesser than the diameter of the cut end of the bile duct, because always jejunal mucosa will retract and the hole will be bigger. Then other important point before you perform this anastomosis is to prevent the mucosa everting. Some surgeons, they would put 5 suture to prevent this mucosa everting, and some would cut the excess mucosa. Other tip is you catch the mucosa always during your placement of sutures, which I describe later, to establish the mucosa to mucosa anastomosis between the bile duct and from the bottom end of the jejunal loop. So this anastomosis can be performed in continuous way as well as the interrupted technique. So Buddhika will discuss about the continuous method. Over to you, Buddhika.
Again, Buddhika, you have to unmute yourself. Buddhika, unmute yourself.
Keep forgetting. Thank you. Thanks, Dominder. The continuous technique is probably the faster one, the one that's easier to learn, but it's also the one that is easier to mess up. It's appropriate in some cases and not so appropriate in others. It's easy when the duct is dilated, and it's probably not as precise when we have a non-dilated fine duct, or when we have to do an anastomosis to a segmental bile duct like the right or left hepatic ducts. And it's also not good practice to use it in pediatric hepaticogenostomies because there needs to be space to grow, etc. So in the continuous technique, important points to remember are: a double-ended suture is used. A single suture is used to complete the entire anastomosis, but there will be 2 knots at the 12 o'clock and the 6 o'clock area so that a complete purse string is avoided. We start at the end that is more distant to us with inside-out sutures placed from the bile duct end and the bowel end. We can place a couple of stay sutures, one at the anterior lip to keep the anterior lip open, and one at the proximal corner so that we can get a length adjustment done. Most of the anastomosis can be done forehand if you're going in this way, so it makes it easier. And at the end, we must remember to place the knot on the bowel side of the anastomosis. Next slide, please. So we'll go step by step. I have drawn a very simplified diagram here. The bile duct looks huge. This is what you would get. Like Dominder said, if you do the procedure under loops, this might be the kind of view that you get. So in this simplified diagram, I have shown the starting suture, which is placed at the 12 o'clock position on the left side of the image. There is also the one stay suture, which I have shown on the anterior side. We should also place another stay suture around the 6 o'clock position, which we won't be approximating until we get to that point. I have not drawn it here because it can make the image a bit confusing, but remember, another stay suture should be placed at the 6 o'clock position also. And that's what gives us the length adjustment as we suture, so that we don't have any excess bowel or excess bile duct left when we complete the posterior side. So the first anastomotic stitch is taken like this in an inside to out and inside to out manner on the bile duct side and the bowel side. If you pay close attention to the bowel side of the diagram, you will know that the stitch is coming out just before the 12 o'clock position and not exactly at the 12 o'clock position. And you'll see why when you look at the second diagram. So the second diagram here shows the next step. We take the suture on the bowel side which has come outside, and we bring it outside to in from the bile duct side. We have to stay about 2 to 3 millimeters. We have to take about a 2 to 3 millimeter bite on the bile duct side. But the corner stitch on the bowel side, we have to take a little bit more, maybe around 4 millimeters, a good thick bite. And remember, always we have to catch the mucosa of the bile duct in that stitch. Sometimes we just accidentally catch only the hilar plate, and that's not appropriate. So once you have gone to that second stage where you have gone through the bile duct again and come from outside to in, now for a right hander, it's a forehand stitch all the way through until you come to the 6 o'clock corner. So once you have put 3 or 4 such sutures, then you can gradually parachute and approximate the bowel to the bile duct with gentle traction, like you can see in the third image there. And here it's the assistant who is key, and we'll probably have to irrigate the suture while we do this approximation from time to time. So as you can see, we gradually progress towards the corner. Like Duminder mentioned, the bowel should be cut a little shorter than the bile duct. When you're progressing towards the corner, if you have a size discrepancy, this is probably the point at which you will make an adjustment and lengthen the enterotomy incision a bit more. Like one of my trainers used to say, you can always make the enterotomy longer, but if it's too long, you can't make it shorter. So it's safer to keep it a bit short, and if necessary, lengthen it at that time. Remember again, I have not shown the 6 o'clock stay suture here for ease of demonstration. And then we turn the corner, previous slide please. And then we turn the corner. When we go on to the anterior side, you'll notice that now the stitch is in a backhand manner, and you are going outside to in on the bile duct side and inside to out on the bowel side. So you stop that suture somewhere around halfway down the line so that you have come out from the bowel side. And then you can complete the anastomosis by starting again from your first suture and suturing forehand. And then you have your knot placed not at a corner, but on the anterior surface. And remember, you have to place the knot on the bowel side so that you prevent cutting through. So I said that I didn't show the corner stitch on the right side. So next slide, please. Once you turn the corner, since you have placed a corner stitch there, you can suture that to the stitch that was continuing, so that you don't have a full purse string, and also you have security. You won't be if the anastomosis, continuous anastomosis, always the risk is unraveling, and you have kind of halved your risk of unraveling if you place a stitch at that corner. Okay, next slide, please. So that would be what a completed anastomosis looks like. These are good for dilated bile ducts, like we mentioned. And here you can also see how the liver has been made more accessible by retracting on segment 4 with the centrally placed retractor, so that the hilum is turned upwards and towards you. Next slide, please. So the important steps here are placing the knot on the bowel side. And this anastomosis, unlike the interrupted anastomosis, most of the work is done by the assistant. If the assistant's tension is too much or too little, the anastomosis might have problems in it. Just to make sure that you're not catching the posterior side when you're suturing the anterior side, you can place a right-angled forceps inside the opening of the anastomosis while you're taking the last few stitches to just separate the posterior surface from the anterior surface of the duct. After the anastomosis is done, it's good practice to wash the area, dry it out, and place a clean swab around the anastomosis, which you will inspect later to check for presence of bile leaks. and it's always a good practice to place a drain at the site of the anastomosis later on. So over to you, Duminder, to describe the interrupted technique next.
So in interrupted technique, assistants also play important role, but it's under your control. So what we do here is just concentrate on this diagram. So this is the cut end of the bile duct. So before you put any sutures, you need to have a clear plan where I am going to take the bites, because otherwise it will cause multiple punctures in the bile duct. So first key thing here is to put the two anterior corners. So if you look at this diagram, it shows the corners which has been placed. So how do you do this? You need instruments like Gerard forceps here to catch your needle maneuver. Then at the anterior corner, your needle will come from the bile duct from outside to inside. Then you keep it on a rubber shot. But when you are taking this bite, you need to make sure your needle goes right angle you puncture the bile duct at a right angle, then you follow the curve of the needle and you make your movement from the wrist to get a precise bite. So you do the same step for the left hand corner again. So these are the two anterior corner stitches. So corners are very important here, because corners, otherwise it will result in a leak. So one of the main trick here is that. So then once you do that, you can put another anterior suture. Again, the puncture is from outside to the inside of the bile duct, then lift it with a rubber shot. So once you do this, then you can decide how many more sutures you require to complete the anterior layer of the anastomosis. Then you keep all these sutures on rubber shots on the top end of the patient without entangling each other. So you can use a robots, or you can place them nicely without any entanglement. And if you look at this intraoperative image, it shows the effect of such a suturing technique. This is the anterior layer, all the sutures has been placed. Then again, a few tips and tricks here. The irrigation is important. The stay suture are very important here, as I mentioned. And also when you are tying, always knot is on the bowel side to prevent the cut through. And when you do the posterior layer, you need to remember your knots will be inside the anastomosis on the bowel wall. Here, depending on your ducts, whether they are dilated or not, so you can use a range of needles, whether you are doing adult or pediatric. So usually 8 to 16 millimeters, half a circle needle is the ideal. So this is the posterior layer. Again, to do this, you need to put two posterior corners, and here you need to take bites from the bowel end inside, then come out from the bowel end, then puncture the bile duct outside and come inside the bile duct. Like that, you need to place a series of sutures in between the stay sutures and with a precise intervals. So once you do that, you can tie the knots to complete the posterior layer, which is shown in this diagram. So this is the completion of the posterior layer. Now your anterior layer sutures are placed. So then you need to complete the anterior layer. So you need to take the needle and get a good bite with catching the mucosa from the jejunal end. Again, keep them without tying. So tying will be done at the end. So when you tie again, ask your assistant to lift the next suture. So then you can properly see where are you going to parachute your suture, the knot to the bowel side as you go along. So again, when you are tying the corners first. These are other trick which is important to prevent the bile leak. So this intraoperative image again depicts completion of such anastomosis. And in this video, I will show you how to do this, how to put these knots. So always squaring your knot is important. And in monofilament sutures, you need about 6 to 8 throws. And always your knot should be on the bowel wall, not on the bile duct. Are there any alternatives? Buddhika?
Buddhika, again, you have to unmute yourself. And Buddhika, we have about 5 minutes.
Sure.
So, yeah,
I'll be very
we have 5 minutes and it's, yeah.
Sure. So side-to-side anastomosis are sometimes done if we cannot resect the bile duct. It's not common in strictures where the posterior layer of the bile duct is tightly adhered to something like the portal vein. We might not be able to resect the bile duct, so we'll resort to side-to-side anastomosis, and also in some palliative surgeries. But in these cases, we have to remember that a condition called sump syndrome can occur because the distal bile duct is not drained, and it can be a nidus for stone formation and cholangitis. But it's sometimes necessary to do that. Sometimes after the resection, the left and right bile ducts might be separated. And so an alternative approach where a dual hepaticogenostomy is placed is sometimes done. There are advantages and disadvantages to doing it on the same rule loop as opposed to two separate rule loops. And of course, recently, mechanical hepaticogenostomy with a small stapler, a 21 millimeter CEA, has been described. But again, this is easy for dilated ducts. Stapler anvil will not go through a non-dilated duct. Okay, so I think we've discussed pretty much what we wanted to about the technique. Dr. Arinda, over to you to talk about any troubleshooting issues.
Yeah, so we have 2 minutes or so. So one main problem, Buddhika, is that when you are dissecting, sometimes if you get a bleeder from right hepatic artery, like if it starts bleeding, what will you do? I mean, how do you tackle that? Because then you can't see the visibility is there, then you get excited. So how do you treat that? How do you deal with that?
Yes, I think the main is not to panic and go and clamp things or use monopolar diathermy there. Most of these bleeders tend to settle, but it's important to identify the exact point of the bleeder with a bit of washing, and perhaps place something like a dry swab on that artery and give a bit of pressure for around 5 minutes. Doing a Pringle is usually not necessary. It's not needed. Just direct pressure on that bleeding point of the artery settles most of these bleeders. If you want,
as you said,
we can all
real necessary, but if you really want to put a stitch, then if it's really disturbing, then you might put a Pringle somewhere else, but not to put clamps there at that point because it makes it worse. So if the swab test, when you are putting the swab, if it becomes positive, what will you do, Dunminda?
Again,
the swab test become positive after bile anastomosis, after all that lengthy anastomosis, what will you do?
Yeah, that depends
on the
which operation you have performed. Like for an example, if you do a liver resection, then bile can leak from somewhere else. But again, you need to make sure that it's really coming through the anastomosis. So if it is from the anterior layer, if you can get another bite, I would advise to do extra bite. Otherwise, if it is in the posterior, it would be really, really difficult. In that sense, I would keep a wide bore drain like 24 to 28 IC tube, and I will come out and I will sit tight and see what's going on.
Yeah, so yes, because if you try to put stitches to the posterior layer, invariably going to damage something and make it worse, and they catch the posterior and completely occlude the lumen. So not to mess with the posterior layer. Good. So then following this, it will persist at the high bilirubin level. After anastomosis, you do your bilirubin level, it will be high, and the alkaline phosphate is also a bit high. So this worries everybody. So what is your approach, Buddhika? What will you do at this?
Several concerns there. The most worrying one, obviously, is that we have caused a narrowing at either the main duct or a major segmental duct. So imaging is key here. We'll probably have to start with an ultrasound to look for dilated ducts, followed by, if necessary, an MRCP. If ducts are dilated, the PTC might also help. But we need to be really sure that this rise in bilirubin and alkaline phosphatase is actually due to an obstruction also, because we have done a major hepatectomy Small size in the remnant can cause the same kind of clinical picture. If the patient was jaundiced preoperatively, with the surgery, there might be a slow drop in the bilirubin and alkaline phosphatase. So I think sitting tight for the first few days and then starting with an ultrasound would be better.
Yeah, so that will answer. It's a complex situation, so you have to look at the situation. Yeah.
Yeah.
Yeah. So I think we will stick to the long discussion. It's a bit too long to be discussed now because we have come to the end of our session. It's almost 8 o'clock. So any questions there from the audience? We have 2 minutes.
I think
For any questions from the audience?
Buddhika, congratulations on your and Duminda, congratulations on a good presentation. What would you use to divide the bile duct? Is it diatemy, scissor, or knife?
Yeah, that's a good question, Suchinta. The cleaner the incision, I think the better the vascularity at the end. So never diatemy. If possible, a number 11 blade would be good. It does cause a lot of bleeding and it's distressing, but like I said, we have to deal with each individual bleeder later on. In the case of a very dilated white duct, sometimes we do use a Metzenbaum scissor as well, but that also does crush the edge a bit.
in terms of
for a training,
time
I think
restrictions,
scissor is, I suppose, is better than for a training. If you are once you are conversant with it, knife, because cutting it, sometimes it might cut the posterior.
Yes, again, just to add one point, when you divide the bile duct, always make sure you replace right hepatic artery is not going behind. But
yeah, exactly. So,
okay. Thank you very much for that very educative session, Dr. Dasanayaka, Dr. Subasinghe, Dr. Arinda Dhammapala. We will be moving on to the next item on our list. The next item on the list will be the first plenary lecture for today, the current management of colonic polyps. Let me invite Professor Kemaldeen and Dr. Niroshan Antalugama to chair the session. Over to you, sir.
Very good morning to everybody, all those who are here and online. Let's take off very quickly with our very first plenary session, and an interesting topic, colonic polyps. As we all know, the incidence of colorectal cancer in South Asia, particularly in Sri Lanka, is increasing rapidly. And in addition to cervical cancer, which is a wholly preventable condition because there's a pre-existing pre-malignant stage, colorectal cancer is the other one. And so without further ado, let me introduce Professor Punyangani De Silva, our very own, working at the Harvard Medical School. She is an assistant professor in gastroenterology and hepatology and endoscopy. My co-chair here is Niroshan, who will also be a part of these sessions. I'm told that plenary sessions don't come with questions, but if you have any burning questions, just pass it on online and we will get in touch with Punyangani for the answers at a later date. So Punyangani, over to you, ma'am.
Good morning. I'd like to thank the President and the Council of the College of Surgeons of Sri Lanka and the Organising Committee of the Sri Lankan Surgical Congress 2021 for inviting me today. Colorectal cancer is among the top 3 most frequently diagnosed cancers worldwide, with an annual incidence of 1.8 million cases in 2018. It's a leading cause of cancer mortality, and in the US, the lifetime risk of developing colorectal cancer is about 4% for men and women. While the median age of diagnosis worldwide is about 67 years, there has been a worrying trend with a rising incidence in younger adults, with overall colorectal cancer-related deaths under the age of 55 increasing annually by 1% since 2008. The majority of colorectal cancers still remain sporadic, and we know that conventional adenomas are precursors to about 2/3 of all cancers, whereas the remainder are derived from sessile serrated polyps. The 5-year relative survival rate for patients with colorectal cancer is about 65%. It is better if one has localized disease, but if there is distant disease, then it just plummets down to about 14%. So it's imperative that patients undergo effective screening, and colonoscopy remains the gold standard for this. Because of the increase in colorectal cancer deaths in younger individuals, the new US Multitask Force guidelines also recommend that asymptomatic screening start at the age of 45. Now, in order to ensure the best possible outcome after a colonoscopy, one does need to optimize polyp detection as much as possible, both before and during the procedure. Patients should therefore be instructed properly on their diet for a week prior to their procedure, and should have an appropriate bowel preparation prescribed to them which they can be compliant with. The scopes themselves have also undergone significant improvement over the years, so we now have these high-definition scopes which are able to provide narrowband imaging. There are these new wide-angle scopes which provide panoramic ultra-wide angle view which exceeds 300 degrees, and also there are multiple CAP-assisted devices that can be used as attachments to the end of the scope to help push back obscuring folds and improve visibility. Endoscopists are also now better trained, and they are also encouraged to monitor their adenoma detection rates and continually improve on this. A recent study at a tertiary center found that proficient endoscopists with an average withdrawal time of 9 minutes had higher adenoma detection rates than those with the standard minimal withdrawal time of 6 minutes. Carbon dioxide insufflation instead of air is better tolerated by patients and allows for a more thorough exam, and endoscopists are encouraged now to learn and understand chromoendoscopy and narrowband imaging to identify abnormal pit patterns. The transparent endocap is a polyp detection add-on device that improves mucosal visualization by straightening the colonic haustra and keeping the colonic lumen open with minimal air insufflation. But it does project about 4 millimeters beyond the distal end of the scope, so it's associated with a learning curve. The endocuff consists of soft projections that remain flat during scope insertion, and then they open up on withdrawal to enhance mucosal inspection. It fits entirely over the scope, so there's no reduction in peripheral field of view. And the endoring has 2 soft circular silicone rings that divert the mucosal folds on withdrawal. While these devices do help, studies have shown that skilled examiners find high image resolution more important for polyp detection than angle view, as the endoscopists are able to compensate for more limited angles by manipulating and deflecting the scope tip. There are other low-cost optimization resources that are commonly used to improve polyp detection rates. A second observer has been suggested, but it's not really practical unless you're in a training list. There is also the dynamic position change, which many of us who do colonoscopies are very familiar with, and we all know how changing the patient position during a procedure can help visualize the colon better. More recently, water-aided colonoscopy with either water immersion or water exchange technique has become very popular. Here you use water instead of air or carbon dioxide to distend the colon and visualize the way forward. Once the operator reaches the cecum, the fluid is then suctioned out and withdrawal undertaken. The technique appears to reduce angulations in the colon and facilitates advancement with less looping of the instrument, particularly in the sigmoid colon because of the weight of the water that pushes it down and thereby straightens out the loops. And in a recent systematic review of nearly 45,000 patients, comparing these various polyp detection methods, they found that the low-cost optimizing resources such as water immersion or water exchange and patient position change were actually the most effective. This slide just outlines the criteria for a high-quality colonoscopy, which is the basis for determining follow-up surveillance intervals. If there's any concern that a high-quality colonoscopy was not performed, then any surveillance or screening follow-up times need to be shortened. As we discussed earlier, sessile serrated polyps make up a third of precancerous polyps in the colon. The rest are conventional adenomas. I am going to focus on sessile serrated polyps for the purpose of this talk, as there's been a lot of new information with regards to this in polyp management, and we do have a very limited time. But they are a type of serrated lesion which also include benign hypoplastic polyps and traditional serrated adenomas. The SSPs and the TSAs are both premalignant, but the TSAs only account for less than 1% of all serrated lesions, so the bulk of premalignant lesions in this group are from the SSPs. Here you have an endoscopic view of a hypoplastic polyp, which is pale and flat, and usually tends to occur in the distal colon. The histology will show a mild serration resembling cul-de-sacs. In contrast, a sessile serrated polyp endoscopically looks like a flat polyp with very indistinct borders. They tend to have this mucus cap on top, which can be misleading, and once this is washed away, it can often be very difficult to detect endoscopically. On histology, you can see a cystic change at the base and these boot-shaped crypts. With traditional serrated polyps, you have very deep serrations on histology. Now, this forest plot shows findings from a recent study which was undertaken to identify risk factors associated with colorectal cancer and their association with development of SSPs and conventional adenomas. All patients had a lower endoscopy and then completed questionnaires every 2 years and were followed up until a diagnosis of a first polyp was made. And these are the numbers of the cohort here. Cigarette smoking, a raised body mass index, and alcohol intake were all associated with increased polyp development, and interestingly, they were all significantly more associated with the development of sessile serrated polyps than conventional adenomas. Exercise, good levels of vitamin D, and marine omega-3 fatty acid intake were all found to be protective against polyp development. The carcinogenesis pathway in colon cancer is intricate, and it is influenced by multiple factors including genetic and environmental. SSPs tend to be more BRAF mutation driven compared to conventional adenomas, which tend to be more KRAS mutation driven. There's also increasing evidence to suggest that the gut microbiome plays a role in colorectal cancer pathogenesis, with increased levels of bacteroids, Fusobacterium, and E. coli seen in individuals who develop colon cancer. Now, we talked about the epidemiology of polyps and a little bit of background of risk factors. But once someone develops a benign colon polyp, treatment really should be endoscopic. Standard cold or hot snare polypectomy can be used for benign and pedunculated polyps. We use endoscopic mucosal resection, or EMR, for larger polyps which have no evidence of invasive cancer. And endoscopic submucosal dissection, or ESD, is used for polyps which are greater than 1 centimeter with appearances suggestive of early invasive cancer. But if a polyp shows features of deep invasive cancer, such as an ulcerated appearance or bleeding, surgery needs to be considered. The goal of EMR, or endoscopic mucosal resection, is to achieve a completely snare resected lesion in the safest minimum number of pieces, with adequate margins and without a need for adjunctive ablative techniques. It's a technique that doesn't require an advanced endoscopist. It can be perfected by a general gastroenterologist. And in this recent study comparing EMR outcomes by general gastroenterologists with advanced endoscopists, there was a similar recurrence rate after EMR of non-pedunculated large polyps, more than 2 centimeters in size. While the advanced endoscopists did have less intraprocedural bleeding, post-polypectomy bleed rates were comparable between the two groups. This slide demonstrates the submucosal lift that we utilize in EMR and ESD. Because saline is inexpensive and widely available, we tend to use it. But one disadvantage is that the saline can dissipate very quickly, so it provides only 1 or 2 minutes to perform a resection. Another disadvantage is that it's clear, so not easily visible to identify polyp margins. You can therefore use a combination of a blue dye, such as methylene blue or indigo carmine, and a viscous agent to maintain the vertical elevation for longer. We tend to use Elaview, which is FDA approved, but other agents can include hydroxyethyl and hydroxypropyl methyl cellulose. EMR has been shown to be very effective for benign colorectal lesions. This is a very recent study that was presented this past November at the American College of Gastroenterology sessions, and it compared cohorts who underwent EMR to those who underwent partial colectomy for benign large colorectal polyps. The individuals were followed up over a decade for new colorectal cancer diagnosis. What the study found was that all-cause mortality was lower for the EMR group compared to the surgical group, and there was no difference in new-onset colorectal cancer between the two cohorts. Now, although the majority of polyps are benign, some do mutate and develop high-grade dysplasia with eventual invasion of these dysplastic elements into the submucosa. These are otherwise known as malignant polyps or submucosally invasive lesions. Even just a 1 millimeter deep neoplastic invasion into the submucosa can allow for a possible lymphatic and vascular metastasis and a high risk of residual cancer. So if a malignant polyp with deeper invasion is suspected, then en-bloc resection is recommended, along with biopsies of suspicious areas with a view to surgical resection. Now, when performing a colonoscopy, there are certain features that may be visible to the endoscopist that are suggestive of this deep submucosal invasion. One is the size of the tumor. If it's larger, greater than 2 centimeters, then there's a higher risk of malignant transformation with deep infiltration. Lateral spreading tumors are another feature. They're non-polypoid lesions, which are more than 1 centimeter in size, but they have this low vertical axis and extend laterally along the lumen wall. They are subclassified into granular types, which have a grainy appearance, and non-granular types, which are much smoother but depressed. And when you see lateral spreading tumors in the colon, you need to consider en-bloc endoscopic resection with either EMR or ESD. Advanced imaging techniques are now very helpful when trying to look for deep infiltration, and dye-based chromoendoscopy can be very helpful. Here you can see that there is this pitted, deep scarred appearance, which is concerning for deep infiltration. The dye also helps to delineate the margins of the polyp better. Electronic-based image enhancement, such as NBI, is very helpful. We use the NICE classification, which grades polyps into type 1 to type 3. If it's type 1, it's a benign hypoplastic polyp. You can see that the color is the same or lighter than the surrounding background, and there are no visible vessels, and the surface patterns are uniform in size. With type 2, this is an adenoma, there's a brown color relative to the background, and the vessels show us these little punctate brown spots surrounded by white structures. But type 3 is very likely a malignantly transformed polyp. It has brown to dark brown color with patchy whiter areas. Vessels are visible, but they're disrupted, and the surface pattern is generally amorphous. And these are some other imaging modalities that are less frequently used to differentiate malignant infiltration from benign polyps. Just briefly about ESD. It was first developed for the en bloc resection of larger flat gastrointestinal tumors. Fluid is injected into the submucosal layer to lift up the lesion, which is then dissected out with special knives. One of the key advantages of ESD over EMR, apart from getting a better en bloc tissue sample, is that there's less recurrence. Although EMR is effective at removing more than 95% of lesions at 6 months, recurrence can occur in 15 to 20%, whereas with ESD, it's around 2%. The disadvantage of ESD is really that it's very time-consuming and carries a higher risk of perforation and requires considerable training. The benefits of ESD are greater for larger lateral spreading lesions, particularly those with low-risk submucosal invading cancer in the distal colon and rectum, where patients have a higher chance of requiring a long-term stoma or a low anterior resection or proctectomy. But its utility in right colonic lesions in someone who's fit to have surgery is less well defined, as a right hemicolectomy is a very straightforward operation with limited risk and lymph node harvesting is assured. Therefore, in an individual with a right-sided lesion, surgery is a preferred option. The British and American societies recently changed their guidelines for follow-up periods after polypectomy. For individuals who have 1 to 2 small adenomas less than a centimeter in size, it's now recommended that they be followed up 7 to 10 years after their procedure rather than 5. But if they had a sessile serrated polyp removed, then the follow-up period can still be 5 years, particularly if it's on the right side of the colon. Based on the new guidelines for malignant polyps, if the polyp is pedunculated and a complete en bloc resection has been performed, then the patient can enter a surveillance program. However, if the polyp shows any unfavorable histological criteria such as deep submucosal infiltration, positive margins, poor differentiation, or lymphovascular invasion, then there should be a referral made to surgery. With non-pedunculated or sessile polyps, based on the NICE classification, if the polyp shows NICE 1 or NICE 2 criteria, then EMR or ESD can be considered. However, if there is NICE 3 features shown in this large polyp, then polypectomy should not be attempted, biopsies should be taken, and the patient should be referred for surgery. So, in summary, colonoscopy is an effective tool for the detection and removal of precancerous polyps, and we talked about how polyp detection rates can be optimized. And while advanced imaging techniques do improve differentiation of detected polyps, they don't significantly increase detection of polyps over low-cost methods such as water immersion. ESD should, however, be considered for submucosally infiltrating left-sided distal lesions, but surgery remains the resection method of choice for right-sided malignant lesions. Thank you very much, and I'd be happy to answer any questions.
Thank you, Professor Pugnagani. Anyway, we don't have time for questions today, but you can post them online. That was a very informative update, and hope to see you next time in Sri Lanka. So that's the end of first plenary. Thank you very much.
Thank you very much, Professor Kemaldeen and Dr. Niroshan Natalugama. We move on to the plenary number 2. It is on management of head injury patients in non-neurosurgical units. Let me invite Dr. Nirukshan Jayavira and Dr. Amila Jayasekara to chair the session.
Good morning, everyone. So we are going to the second plenary session today morning. This neurosurgical lecture will be delivered by Dr. Nilaksha Kumar Singh, who is a consultant neurosurgeon working at Teaching Hospital Kurunegala. His involvement in management of a lot of trauma and non-trauma neurosurgical and critically sick neurosurgical patients. So he's today going to talk about neurosurgical management of patients in non-neurosurgical units. Over to you, Nilaksha.
Good morning, ladies and gentlemen. I'd like to thank the College of Surgeons, the Council of College of Surgeons, for giving me this opportunity to make this presentation. My presentation today is management of head injuries in a non-neurosurgical unit. So if you look at the neurosurgical units in the country, about 25 years ago, there were only 2 units in the public sector for the entire country. And you had to transfer all the patients from all over the country to these 2 units. But then you can imagine the condition of these patients. But fortunately, during the last few years, we have had so many neurosurgeons after training. And there are 14 neurosurgical centers throughout the country. And most of these centers have 2 or more neurosurgeons, except in Batiklu and Ratnapura. So all these centers have weekend cover as well. So my advice is get to know your local neurosurgeon responsible for your region, get in touch and communicate. And if there's any doubt, speak to them. And we like to get your feedback, whether it's positive or negative, so we can improve things. These centers also have problems like poor manpower, theater time, anesthesia issues, but we'll try to do the best to help you to overcome the problems. So when you talk about management of these patients in a non-neurosurgical, there are few scenarios that I can think of. One is acute management of a patient with head and spinal injury. Soon after the injury, the patient will come into the hospital, the nearest hospital. Then you have to resuscitate, assess, and make a decision to transfer the patient. You may have a CT machine. Some of the peripheral hospitals have CT machines now. That's a good thing. Or you have to transfer to a center for a CT scan. Then you may have to manage mild or moderate head injury patients in your unit, because you don't need to transfer each and every patient to a major hospital. And there will always be patients coming back from a neurosurgical unit for continuation of care, especially in severe head injury and spinal injury patients. Before sending home, they will need some time to rehabilitate and prepare the family for the patient to be taken home. So that's the other scenario. So briefly look at these, the etiology. We have a lot of road traffic accidents, especially motorbike accidents, 3-wheelers, alcohol intoxication, fall from heights, assaults, and industrial injuries. Sports injuries are sometimes seen, but not very common. So the management always starts with, according to the ATLS guidelines, airway, breathing, and circulation. And when it comes to neurological and surgical problems, disability and exposure. So I'll speak a bit more about disability. This is where you assess the Glasgow Coma Scale score and assess the pupils and examine any signs of lateralizing signs and signs of cord injury. And exposure, so you expose the patient, including the back of the patient, and don't forget to palpate the spine from top to bottom to make sure there are no injuries in the back as well, and prevent hypothermia. Assessment of Glasgow Coma Scale is extremely important, because it's the baseline of the assessment, and we'll compare it later. So whenever a new medical officer or RHO comes to the unit, the first thing we teach is how to properly assess GCS. And it's not correct if you guess the GCS looking at the patient, because you always make mistakes. So you have to go by the different components and give individual scores and document individual scores and take the total. So it's always good to educate your juniors on how to assess GCS. There can be problems in assessing GCS. For instance, after trauma, there may be swelling of the face and the eyes. There may be patients with dysphagia. The patient may come with the tracheostomy, spinal injured patients. Children, it can be a problem to assess GCS, but there are modified scores for children, but they're not very practical. Mentally, physically disabled patients, especially sedated patients. If you send for a CT scan and sedate, then you have to note that. And especially after any event of seizure, there'll be some drowsiness, and so then you have to document that as well and clarify. So focused neurologic examination, part of the disability assessment, inspect for skull fractures, base of skull, optic nerve function, the vision and the pupils, do a motor examination, do a sensor examination. If there are any sensory deficits, just look at the sensory level, look at the major dermatomes, joint position sense, and if there are any evidence of sensory impairment, look at the basic reflexes. So according to the GCS, head injuries are classified into 3 groups. GCS 14 and 15 is minor head injury, 9, 10, 11, 12, 13 is moderate head injury, 3 to 8 is considered severe head injury. Now, as I said, there are many CT scans in the country apart from the neurosurgical centers. So you need to know the indications for CT scans. These are the NICE guidelines. It's good to know them. If there's any patient coming with the GCS less than 13 in the initial assessment, and if the GCS is less than 15 after 2 hours after admission and resuscitation, any suspected skull fractures, any sign of base of skull fracture, more than 1 episode of vomiting in adults and more than 3 episodes of vomiting in children, post-traumatic seizures, all these patients need a CT scan. And in an emergency setting, it's recommended that CT is done within 15 minutes and interpreted within 1 hour. To continue, if there's any focal neurological deficit, you need a CT scan. And even if none of these above are present, if there's retrograde amnesia, elderly patients, if the mechanism of injury is dangerous, patients on anticoagulation and intoxicated patients after alcohol or drug abuse, there should be a low threshold for a CT scan because there can be problems. Don't forget some of these patients after head injury present late, especially with chronic subdural hematomas and things. So if there's any change in consciousness, behavior, progressive neurological deficit, slurring of speech, late onset seizures, CSF leaks, headache and vomiting, and even in non-accidental injuries in children may present after some time. So you have to be vigilant about these things. So something very important regarding transfer, the one on the left is a spinal cord, and which stabilizes the patient's spine and the head for transfer. And the one on the right is a PAT slide, which makes it safe for when you transfer the patient from the bed to the trolley and to the theater bed. So it's always useful to have these 2 equipment in your unit. So as I said, you may see these CT scans. So just to remind ourselves, so the one on the left upper side is thin STH with a mass effect and a massive midline shift. The one on the right up is a biconvex shape extradural hemorrhage with mass effect. This is a diffuse injury with some microhemorrhages. One on the right is with dark black patches of pockets of air in neocobolus. This again you see a thin STH, a thin EDH, and traumatic SH with some thin STH. There's a deep breast fracture with some air pockets indicating it's a compound deep breast fracture. These bifrontal contusions. So in patients, you see patients like this, there will be always some cerebroedema gradually, and they tend to deteriorate. So if you see this scan, so don't keep the patients into neurosurgical. I mean, most of the time they need a decompression. This is a cerebral edema patient. And don't forget and this is a bad CT scan that I want to show you, a patient with coning and herniation. You see there are no, if you look carefully, no base assistance seen. There's some false subarachnoid-like appearance, and there's darkening of the frontal and middle cerebral areas with ischemia. So this patient is coning and it's already coned. So if you look at the pupils, that will be like 6 non-reactive. So when the patient comes to us in this situation, there's nothing anybody can do. So the prognosis is very poor. We will not be able to do anything. So we may have to just leave the patient alone or transfer back because the prognosis is very poor. And don't forget the spine, cervical spine. When you do a CT brain, always ask for a cervical spine, especially the upper and lower areas of the cervical spine are very poorly visualized in X-ray. So go for the cervical spine as well, because it takes only a couple of seconds for the patients to do a cervical spine. So in the recommendation of blood pressure, keep the pressure up. Don't avoid hypotension, systolic less than 90. Keep it above 90 because the hypotension will affect overall outcome of the patient. Whether to give mannitol, there are indications and contraindications. It's used to buy some time in a patient developing a mass effect until the patient is taken into the theater. So basically what I feel is, if you think a patient needs mannitol, then better to transfer the patient to a neurosurgical unit and observe or do something there without treating with mannitol in your units. There's no indication of steroids in traumatic brain injury. That is the only thing with the level 1 evidence, according to the Brain Trauma Foundation guidelines, that says there is no use of steroids in patients with head injuries. Tracheostomy, we do perform tracheostomy quite often because that's the easiest way to get a patient out of the ICU. And the ICUs are a precious resource. Even in Sri Lanka, all over the world, there's high demand for ICUs. So get them out of the bed and make room for new patients. We need to take the patient back to the ward. So we take them in the tracheostomy with the TPs and reverse the tracheostomy after some time. Although it doesn't improve evidence in chest infection or mortality, but it's very useful to get the patients out of the ICUs. We are quite liberal on these prophylaxis because most of the patients are poor patients. They don't listen when we say not to work for 1 month. They can't do that. They have to go back to their work. Some of them are drivers. Some of them are construction workers. Some of them climb trees. So we can't just leave them. So we tend to start antiepileptic. It used to be phenytoin, but now we go for levetiracetam because levetiracetam has a better side effect profile, and especially in patients with alcohol and liver issues. Levetiracetam is safe and it's available freely in our hospital, and even for clinic patients, we can issue levetiracetam. Nutrition is very important. Try to start feeding as soon as possible. We may have to use an NG tube for some time. In the ICU, may have to use some TPN, but if the patient is taking time to recover, then PEG is a good idea. Pressure point care is very important because the blood, if they develop bed sores, then the whole recovery process delays. So early mobilization is the number 1 thing. Change position or log roll every 2 hours in spinal patients, and use of water mattress and air mattress are very useful. Especially air mattresses are very comfortable. And it's not that expensive. It's about 20,000 rupees in the market. And even if there are no air mattresses in your ward, ask the patient to buy one for the patient, and then they can take the air mattress home so they know how to use it as well. Children are a special problem because the parents are very anxious when the children come with head injuries, and vomiting is very common in children. So if the child is very well, just 1 or 2 episodes of vomiting we can observe, and you don't need to rush to do a CT scan. And usually they get these ping pong type pond fractures, green stick fractures, which we can leave alone. They always remodel. Treat them with pain relief, antiemetics, observe and reassure the parents. And other thing about children is, even if they get severe head injury, the potential for recovery is very, very good. So we always do the maximum for children. Even if the condition at the beginning and the CT looks terrible, we will do everything possible for children. So in summary, there's a neurosurgical unit on every province now, and most of the units have 2 neurosurgeons minimum. So there's weekend cover as well. So some of the head injuries can be successfully managed in a non-neurosurgical units. You need to know the indication for CT and how to transfer and when to transfer. Always communicate with the local neurosurgical team, develop a relationship. Most of the surgeons are happy to communicate and get your feedback. In other countries, there are PAC systems where we can access to your imaging systems, especially if you have CT scan, but we don't have that kind of facility. But you can always send good quality image via Viber or WhatsApp. We are happy to see and give you a feedback. So that may avoid unnecessary transfer, or we can make room in the ICUs or make some time in the theaters if you communicate with us, and that's very well accepted. And this is a teamwork, and working together, the benefit will be delivered to the patients. So I'd like to thank you very much again. Thank you for the audience, and thank you College of Surgeons and the Council for giving me this opportunity to deliver this lecture.
Thank you, Nilaksha, for enlightening us on how to manage head injury patients in non-neurosurgical units. Your tips are very useful, especially for us as general surgeons, as we manage a lot of head injury patients in our units, especially in the peripheral hospitals. Ladies and gentlemen, that was Dr. Nilaksha Kumar Singha, consultant neurosurgeon from Teaching Hospital Kurunegala, talking to us on how to manage head injury patients in non-neurosurgical units. And with that, we conclude Plenary 2. Thank you.
Thank you very much, Dr. Nirukshan Jayavira and Dr. Amila Jayasekara. We move on to the third plenary for today. Let me invite Dr. Indrani Amarasinghe and Dr. Nisanka Jayawardena to chair the session. Over to you, madam, and over to you, sir.
Ladies and gentlemen, and everybody online, so welcome to the third plenary of the 50th anniversary of the College of Surgeons. And let me introduce my co-chair. He doesn't need introduction, Dr. Nisanka Jayawardena, past president. Today we have Professor Cheng Ha Yip, the University of Malaysia, and she is the current president of the International Society of Surgeons. She was also the president of the College of Surgeons of Malaysia. She's going to talk to us on a very interesting topic. She's going to talk to us on the impact of clinical practice guidelines, which we all follow, on the mortality of breast cancer patients in low-resource countries. And I would like to welcome her to give us this talk.
I'd like to thank the College of Surgeons of Sri Lanka for giving me the opportunity to give this lecture today. Today's lecture is on the impact of clinical practice guideline adherence on mortality from breast cancer in low-resource settings. What are CPGs? Clinical practice guidelines is a systematically developed statement to assist practitioner and patient decisions about appropriate healthcare for one or more specific clinical circumstances. In the management of breast cancer, there are many therapeutic options available. Team management is emphasized. That is, the surgeon, radiologist, and pathologist work together to arrive at a diagnosis of breast cancer from imaging and from a biopsy. Once cancer is confirmed, the team management is from the surgeon, oncologist, breast care nurse, plastic surgeon, and counselor to determine what is the best management for the patient. Treatment should be based on the best evidence available. Guidelines change every few years. Usually 2 yearly reviews are required. There are many CPGs developed, such as the St. Gallen's, the NIH consensus, the Nccn Guidelines. However, these are developed in high-resource settings. Are they applicable to low and middle-income countries where there are less resources to treat breast cancer? What are the NCCN guidelines? NCCN stands for the National Comprehensive Care Network. These are the most well-known guidelines, and they are used all over the United States of America for treatment of many conditions, including breast cancer. The NCCN guidelines are composed of recommendations based on the best evidence available at the time that they are derived, but it is essential that they be continuously updated and revised to reflect new data and new clinical information. The NCCN guidelines are updated almost every 2 to 3 months as new data emerge. The aim of the NCCN guidelines is to assist oncologists in making the major clinical decisions encountered in managing their patients. NCCN has now developed resource-stratified and harmonized guidelines for countries with different resources. This is because NCCN has recognized that some of the recommendations that are in their guidelines may not be applicable to low and middle income countries which do not have a similar resources to treat breast cancer. Why do low and middle income countries need separate guidelines? Guidelines need to be culturally sensitive, economically feasible, and acceptable to the public. Are treatment guidelines from developed countries equally effective in developing countries? We will need to actually do some studies to find out whether this is true or not. There are many problems facing the healthcare system in low and middle income countries. The public facilities provide the bulk of the secondary and tertiary healthcare services in most of these low and middle income countries, but they offer services of poor quality. The composition of health services offered and consumed can be suboptimal. Healthcare providers cannot be enticed to rural and urban marginal areas, leaving large segments of the population without adequate access to healthcare. The referral system and coordination in the delivery of care is inadequate. Hence, a woman with breast cancer in a low and middle income country has got many barriers in obtaining the optimal treatment that she needs. The concept of resource stratification did not begin with the NCCN. It was just started with the Breast Health Global Initiative in 2005, and the resource stratified guidelines were published in 2006 in the Breast Journal. Breast resource stratification from the Breast Health Global Initiative means that there are 4 levels of resources: the basic, limited, enhanced, and the maximal level. The basic level would probably apply to low-income countries where there may be absolutely nothing to provide healthcare. For example, radiotherapy facilities may not be available, and hence you would need to do a mastectomy even in early breast cancer, because breast conserving surgery would need radiotherapy. At the limited level, there are maybe second-tier resources of services which would produce a major improvement in outcome, and this would mean chemotherapy and radiotherapy. At the enhanced level, there will be third-tier resources or services which are optional and may produce minor improvements in survival. This may be the difference between using a second-generation chemotherapy or a third-generation chemotherapy. At the maximal level, the resources will be a high-level resources, and these are very expensive treatments that may not be affordable in high-resource countries. Example of practicing at a maximal level would be to provide population-based mammographic screening, or it may be to provide genetic testing and counseling, and to provide MRI screening for breast cancer for those who are at high risk. Do guideline adherence improve outcomes for breast cancer? The most important outcome we look at is overall survival, and disease-free survival is another outcome which can be a bit more difficult to measure. There are studies on the impact of guideline adherence on breast cancer in high-income countries. This is a systematic review that was published just last year, which showed that in the European Union, adherence to guidelines was associated with increased overall survival with a hazard ratio of 0.67 and disease-free survival with a hazard ratio of 0.35. This represents 138 more survivors for every 1,000 women receiving adequate adherent treatment compared to non-adherent treatment. And for those for disease-free survival, it means that there's 336 more patients free of recurrence for every 1,000 women receiving adherent treatment compared to non-adherent treatment. Adherence to treatment guidelines was associated with higher costs, which makes sense because if you give more treatment, it will cost more. And more treatment is generally associated with a better survival. Adherence to follow-up guidelines was associated with lower costs. In a country, in Singapore, which is a high-income country, treatment non-compliance was associated with worse overall survival for surgery with a hazard ratio of 2.26. Chemotherapy with a hazard ratio of 1.25, radiotherapy hazard ratio of 2.28, endocrine therapy hazard ratio of 1.7. Worse survival was similarly observed in older patients for whom guidelines generally do not apply. These results highlight the importance of following appropriate treatment as recommended by current guidelines. Older patients may benefit from similar recommendations. Older patients tend to be undertreated because the oncologists or the healthcare professionals may feel that they may be too old to be able to withstand the kind of treatment that they would provide for younger patients. What about the impact of guideline adherence in LMICs? So far, there has been no published paper on this issue. However, in Malaysia, we actually did a study to look at the impact of guidelines adherence on breast cancer survival. This is still under review. It's been sent for publication. In this study, women who were newly diagnosed with stage 1 to 3 breast cancer between January 2010 and December 2017, who underwent surgery as primary treatment were included. Patients with ductal carcinoma in situ, de novo metastatic breast cancer, previous cancers, non-epithelial breast cancer, bilateral breast cancer, or those who received neoadjuvant treatment were excluded. Basically, in this study, we were looking at patients who received adjuvant therapy after primary breast surgery. And adjuvant treatment for breast cancer is hormone therapy, chemotherapy, radiotherapy, and targeted therapy. The key reference document that was used in the present study is the Malaysian Clinical Practice Guidelines on the Management of Breast Cancer, second edition, which was published in 2010 and was in fact up to end of 2019. It was only in 2020 that the third edition of the Clinical Practice Guidelines was published. And the long interval between the second and third edition was mainly because of the lack of manpower in the Health Technology Assessment Unit, which is responsible for developing guidelines. The recommended adjuvant therapy after primary surgery, according to these guidelines, was that we give chemotherapy if there is any lymph node involvement, if the tumor size is more than 2 cm, if the tumor is poorly differentiated, that is grade 3, if it is ER negative, or if HER2 is overexpressed. Any one of these 5 factors would actually mean that the patient should have chemotherapy. Radiotherapy is required after breast-conserving surgery, or in the case of mastectomy, when surgical margins are positive, or if 4 or more axillary lymph nodes are involved. Hormone therapy is required for ER-positive tumors, and HER2-targeted therapy, which is trastuzumab or Herceptin, is recommended for HER2 overexpressing tumors. 3,100 Malaysian women with non-metastatic breast cancer were included in the study. Guideline adherence for adjuvant chemotherapy was 61.7%, radiotherapy 79.2%, hormone therapy 85.1%, and targeted therapy 26.2%. Now, the adherence rate can quite easily be explained. For adjuvant chemo, because of the problems of loss of hair, nausea, vomiting, some patients who actually need chemotherapy decline to have the chemotherapy, hence the lower adherence rate of 61.7%. Radiotherapy and hormone therapy are generally without any side effects, and hence the guideline adherence were higher than for chemotherapy at 79.2% and 85.1% respectively. The reason why only 26.2% of eligible women who needed Herceptin were actually given Herceptin is mainly a cost issue. During the period of the study, Herceptin was still patented, and hence it was very costly, and a lot of women were unable to afford the treatment, even though it was in the guidelines and available in Ministry of Health. Because of budget constraints, only a handful of women were actually able to be given Herceptin. These are the adjusted hazard ratios of 5-year overall survival for chemotherapy, radiotherapy, hormone therapy, and targeted therapy. And for chemotherapy, it was adjusted for age, private or public, patients, ethnicity, radiotherapy, hormone therapy, target therapy, and so on. As for radiotherapy, hormone therapy, targeted therapy as well. So we are using adherence as the reference, and we find that the adjusted hazard ratio was 1.39 for chemo, 3.83 for radiotherapy, 4.39 for hormone therapy, and 3.15 for targeted therapy. In the figures that are available for high-income countries, you'll find that chemotherapy has about the same hazard ratio, but radiotherapy and hormone therapy has a higher impact on survival in low and middle income countries compared to high income countries. All these values are significant. For disease-free survival, we see similar hazard ratios. Again, significant that adherence to adjuvant treatment actually improves disease-free survival. So this is the summary of the results. Compared to patients who were treated according to treatment guidelines, overall survival and event-free survival was substantially lower in patients who were not treated accordingly. And these are the corresponding hazard ratios for mortality, which has already been presented in the tables before. So this study shows that adherence to treatment guidelines that has been adapted for resource-limited settings may still provide effective guidance in improving breast cancer outcomes. The conclusion is that each country should adapt established guidelines to cater for its individual requirements and available resources. Adapting the NCCN resource stratified guidelines to cater for available resources takes less time than developing your own guidelines. It is important to monitor implementation of guidelines and to measure the impact of guideline adherence on survival. Thank you very much.
Thank you very much, Professor Cheng Ha, for that enlightening lecture. I am happy we got together cancer control program in Sri Lanka with College of Oncologists and Oncosurgeons, General Surgeons, and College of Surgeons of Sri Lanka got together, and we also recently came out with a set of guidelines for our own country. And I would appeal in this instance, take the chance of appealing to our general surgeons to adhere to those guidelines. And thank you again for that excellent lecture, Professor Cheng Ha.
Thank you very much, Dr. Amar Singh and Dr. Jayawardena. We move on to the first symposium session for today, History of Surgery. I would like to invite Dr. Jayendra Fernando and Dr. Nisanka Jayawardena to chair the session. Over to you, sir.
Thank you. Good morning. Symposium 1, it's a very interesting topic on the history of surgery. So may I introduce the first speaker is Dr. S. Rajendra, who is a consultant surgeon at the University Surgical Unit, Teaching Hospital, Jaffna. And I invite Dr. Rajendra to make his presentation.
Good morning to you all. I thank the Surgical Congress for inviting me to take part in the symposium about history of surgery. In my talk, I will be focusing on these salient events in the history of surgery in Jaffna. Jaffna Peninsula is situated on the northern tip of Sri Lanka, and it has an area of about 1,000 square kilometers. This existing building in Jaffna is the minister's palace for the last king of Jaffna Kingdom, King Sanglian. Surgical practice in Jaffna in those days was based on Siddha medicine, and the barber surgeons were carrying out the surgical procedures. Western medical care to public was practically unknown in the peninsula till 1800. Arrival of Western surgery. The American Board of Commissioners for Foreign Mission sent a qualified American medical missionary, Dr. John Scudder, in 1819. He was assigned to work in Jaffna. Dr. John Scudder established his dispensary at Pandatharipu, a village about 15 kilometers from Jaffna town. So, Jaffna became unique as the place where the world's first medical missionary work was firmly established. This is Dr. John Scudder and the dispensary at Pandatharipu in 1820, that is about 200 years ago. Dr. Scudder performed many successful operations during 1820s. Some of them are plastic reconstruction of mutilated ears and above knee amputations. These would be amazing achievements in those days when there were no facilities for anesthesia, blood transfusion, and sterility. This is the existing Scudder's dispensary after renovation, and the enlarged view of the plaque on the front wall of the building and the postage stamp released to honor Dr. John Scudder. Dr. Samuel Fisk Green was an American medical missionary doctor practicing in USA. He commenced Western medical and surgical services at Manipai, a village about 10 kilometers away from Jaffna town. This is Dr. Green and the dispensary at Manipai in 1848. Now we will move on to consider providing surgical services to Jaffna community. Acceptance of Western surgery by Jaffna community was a great challenge, but there was a turning point. Dr. Green diagnosed intra-abdominal abscess in a Tamil and Sanskrit Pandit. The native physicians who had been treating this patient had already given up this case as hopeless. Dr. Green cut open the abscess and cured him. So, Dr. Green's fame spread throughout the peninsula, and the people of Jaffna looked upon Dr. Green as a great healer. This book, Life and Letters of Samuel Fisk Green, contains letters written by Dr. Green, describing about the surgeries he performed in Jaffna. Some of them are strangulated hernias, amputation of limbs, and removal of cancers. Nowhere in his letters, Dr. Green mentioned the use of anesthesia. Since Dr. Green practiced abdominal surgery, he must have used anesthesia. The use of ether as an anesthetic agent was first demonstrated by Morton in USA in 1846. Dr. Green was in USA during this time, and it is likely that he brought with him the knowledge about anesthesia. If so, Dr. Green may well have been the first person to use ether in Sri Lanka. Now we will move on to consider medical education and expansion of surgical services. Dr. Green organized the Mission Medical School with 7 students. He taught medicine and surgery in English for 3 years in consecutive small classes. You can see the first batch students graduated in 1850. Dr. Green then introduced Tamil as the medium of instruction for Western medicine from 1864. These are few Tamil books translated from English by Dr. Green. During the 26 years of stay in Jaffna, Dr. Green had trained a total of 87 medical practitioners. Dr. Green left Jaffna in 1874 and passed away in USA in 1884. This is the gravestone of Dr. Green. The epitaph engraved on it is Medical Evangelist to the Tamils. This is the postal stamp released to honor Dr. Green. Dr. William Jameson, an American medical missionary, arrived in Jaffna in 1923. He performed nearly 500 operations per year in those days. Apart from that, he renovated Green Memorial Hospital. This is the Green Memorial Hospital existing in Manipai now. We will now focus on the establishment of government hospital in Jaffna with qualified surgeons. The Friend in Need Society Hospital was established in 1861. In this hospital, Dr. Green and medical practitioners from Green's Medical School were providing surgical services. This hospital was renamed as Jaffna Civil Hospital in 1907. Government appointed qualified surgeons to this hospital subsequently. Dr. Milroy Paul was appointed to this hospital in 1837. He describes the surgical services in Jaffna Civil Hospital in 1930s. Jaffna Civil Hospital had a total of 90 beds allocated for surgical wards. The operating theatre had a vestibule and a main operating room, 12 foot square, with a large glass windows allowing plenty of sunlight, because almost all the surgeries were performed during the daytime. Scrubbing was performed by immersing hands in a weak antiseptic solution of the carbolic group. The gloves were boiled and put on wet. Surgical gown had short sleeves. Cap and mask were washed and not sterilized. Amazingly, there were very minimal post-operative infection those days. Surgeries frequently performed in 1930s in Jaffna were gastroenterostomy, obstructed hernias, intussusceptions, and appendicectomies. Causes for peritonitis in those days were neglected appendix, typhoid perforations, and ruptured liver abscesses. Jaffna Civil Hospital was renamed as Jaffna General Hospital in 1950. You can see many great surgeons who are considered as legends of surgery in Sri Lanka commenced their career in Jaffna General Hospital. We will now move on to consider the development of subspecialty surgical services in Jaffna. Cardiothoracic surgical services were available in 1950s. Closed mitral valvotomy were commonly performed those days. You can see a diagnosis card issued from Jaffna General Hospital in 1970 describing the repair of atrial septal defect by Dr. Ganesh Anandan under hypothermic anesthesia. Dr. Nat Kunam, another cardiothoracic surgeon, performed 98 atrial septal defect corrections from 1971 to 78 with no immediate post-operative mortality. Orthopedic surgical services were available in Jaffna in the 1960s. Dr. Sivanyanavel performed internal fixation, hemiarthroplasty, and knee replacements in 1980s. Neurosurgical facilities were available in 1970s. As a consequence of the establishment of the Jaffna Medical Faculty, General Hospital Jaffna was elevated to the status of teaching hospital in 1980. Surgical services in Jaffna were provided from Teaching Hospital Jaffna, peripheral hospitals, and private hospitals in Jaffna. Finally, we will focus on the effect of civil war and surgical services in Jaffna. Civil war caused severe and prolonged disruptions of transport from Colombo to Jaffna Peninsula. Civil medical stores and biomedical engineering services were based in Colombo. So every surgeon had to work with shortages and improvising to use what was available. Intramedullary nails were re-sterilized and reused due to lack of adequate number of new nails. Gauze towels used in clean surgeries were washed thoroughly, autoclaved, and reused. The shortage of anesthetic gases and subsequent reduction in inhalation anesthesia were overcome by using intravenous anesthesia, regional techniques, and infiltration analgesia. Civil war was so intense that the hospital had to be shifted to different places in order to function with safety for staff and patients. Civil war not only devastated infrastructural facilities, but also caused deficiency in the qualified surgeons to provide services to Jaffna Peninsula. After the end of civil war, that lasted for more than 3 decades, the infrastructural facilities in teaching hospital as well as other hospitals in Jaffna showed tremendous improvement. This is the new operating theatre complex in the teaching hospital Jaffna. Furthermore, general surgical as well as many other subspecialty surgical services became available in Jaffna after the end of civil war. This book describes milestone events in the history of surgery in Jaffna in great detail, and it is available in the College of Surgeons of Sri Lanka. Thank you very much.
Thank you, Rajendra, for that interesting presentation, well-researched, documenting an important part of our historical legacy. And to introduce the next speaker, may I ask my co-chair, Professor Arjuna Alavihare.
The next speaker is Dr. Buddhika Disanayaka. He is from what used to be my university, Peradeniya, lecturer in surgery in the Department of Surgery in the Faculty of Medicine, Peradeniya.
Good morning and welcome to this brief presentation on the history of surgery in Sri Lanka. So we will be progressing through 3 sections in this presentation. We'll be starting with a discussion on history of surgery in ancient Sri Lanka from classical to medieval periods, followed by how European influence on surgery in Sri Lanka started with the advent of the age of sail, and lastly, a short description of how current surgical practice as we know it now emerged around the turn of the 20th century. So to start with discussing the history of surgery in Sri Lanka, it would be useful to establish the chronology of Sri Lankan history itself. Sri Lanka has quite a long history, ranging back to perhaps 1000 BC or more. The first megalithic evidence of cultures range from around 1000 BC to the 4th century BC. But the classical period of Sri Lankan civilization started around the 4th century BC in the kingdom of Anuradhapura and extended through to the kingdom of Polonnaruwa, which went on until around 1200 AD. Following which there was a period of unrest and the kingdoms changed rapidly over the next 600 or so years until 1815 when the kingdom of Kandy was ceded to the British. During this same time, Sri Lanka began to get exposed to Western cultures, first starting with the Portuguese who landed in Sri Lanka in 1505. And the Portuguese established control over the coastal belt of Sri Lanka and continued controlling these areas until the 1650s, when they were replaced by the Dutch, who again controlled roughly the same areas until the late 1700s. The British gained control of the coastal areas in the 1700s and gained control of the entire country around 1815. and Sri Lanka gained independence from the British in 1948. So with this background in mind, we'll talk first about surgery in ancient Sri Lanka. Being an island situated close to India, Sri Lanka had was influenced largely by surrounding countries. Sri Lankan surgery was influenced by the science of life or Ayurveda from northern India, the Siddha tradition from southern India, as well as by Arab and Persian traditions of Unani medicine. The first records of surgery in Sri Lanka range back to the Mahavansa, or the Great Chronicle, which narrates how hospitals were organized, and there gives anecdotal evidence of surgical procedures, including how arrow wounds, etc., were treated from the Anuradhapura period. Sri Lanka also boasts numerous Ayurvedic texts. Indian texts were used here, including the Susruta Samhita, which gives descriptions of surgical procedures and instruments, and is quite an old textbook used in India as well. There are also several indigenous texts, the most significant of which is the Sarartha Sangraha, written by the sage king Buddhadasa somewhere around the 4th century of the Common Era. And Buddhadasa was a pioneer in hospital building, and there is anecdotal record of human and veterinary surgery that occurred during this period. So in addition to the epigraphic evidence, the Sarartha Sangraha also gives detailed descriptions of anatomical landmarks in both animals and humans, and shows probably the first written descriptions that we in Sri Lanka have of old surgical implements as they were used in the classical era. Added to this epigraphic evidence is archaeological evidence. Mihintale, ranging back to the Anuradhapura period, has one of the oldest hospital complexes in the world, whose history probably goes back to the 1st century before Christ. It's a very well organized hospital with an inner court faced by patient cells, a separate area for preparation of medicines, for storage of medicines, and this structure continues through most of the old hospital systems that were excavated in Sri Lanka. Retigala again goes back in history to the Mihintale era of the 1st century BC. Around the 8th century of the Common Era, another hospital was established around Madirigiriya, and remains of this also exist to this day. Most of these hospitals, as you see, used immersion baths for treating patients. The last hospital in this range that I'm going to talk about is the Alahana Pirivena Hospital from the Polonnaruwa era, which was established around the 12th century. So added to this archaeological, the epigraphic evidence of ancient implements is archaeological evidence of surgical implements used here. Most of this information comes from excavations carried out at the Alahana Pirivena site over the past 3 decades, and a range of instruments used in the hospital system were excavated there. These included beetle nut cutters, scales that were used in measuring out fine grains of medication, and also probes, which were probably used in treating fistulae, lancers that were used in drainage of abscesses, and also scalpels, which are very similar in shape and form to currently used instruments, forceps, both fine and coarse, as well as scissors. So these old surgical implements excavated at the Alahana Pirivena Hospital bear a very strong resemblance to their current counterparts, and shows that the techniques or the materials that were used by surgeons of 1,000 years ago were probably very similar to the ones that we see these days. Moving on to surgery in the medieval period in Sri Lanka, from around the 13th or 14th centuries up to the 18th century. Certain instruments have been discovered. Some of them have found their way to collections overseas, notable of which is the Casey Wood collection in McGill University, which boasts a wide range of Sri Lankan medical and surgical paraphernalia from the medieval period. And also, around this time, the Portuguese and the Dutch evinced a great interest in native Sri Lankan medicine and surgery. And they did write textbooks starting from the 1600s on Sri Lankan medical traditions. These were probably the first two medical textbooks published in the West on Sri Lankan medicine. From around this time, there were also European accounts of surgery in Sri Lanka. Robert Knox was probably the first to give descriptions of how native surgeons treated ulcers, tonsillitis, eye infections, etc. Added to this, Ribeiro from the Portuguese period does give some descriptions, but they are probably fanciful, claiming that fractures could be healed within a few days and malignancies could be treated within 8 days or so. Major Forbes from the British period describes how abscesses were drained and how cauterization and venesection was practiced. He also gives this very interesting description of how a native surgeon relocated a dislocated ankle using the pliability of a young sapling, and how the patient regained full function afterwards. Henry Charles Sir from 1850 describes how amputations were done and how amputated stumps were cauterized. So this brings us now to how European influence on surgery in Sri Lanka started. Again, we will start from the Portuguese period, when the Portuguese established their control over the coastal area. They built several hospitals. The first of which was in Colombo. No evidence of this remained. There was an admixture of local and European techniques used in these hospitals. Venesection was done using surgical implements as well as leeches. The Dutch improved on this hospital system. They developed an extensive coastal hospital system. The Colombo Hospital records a large number of surgeons from this time as well as plenty of patients. And in fact, the Dutch also attempted to treat surgical conditions in the native kings of Kandy and sent surgeons to Kandy for this purpose in the 18th century. The Dutch hospital in Colombo still exists and is probably the oldest hospital from the European era that exists in Sri Lanka. The Handala Leprosy Hospital comes a close second. It was established in 1708 and still functions. Famous Dutch surgeons in Sri Lanka include Paul Herman, who Carl von Linné described as the prince of botanists, and Wouter Schouten, who was a famous author. Lastly, we'll come to the emergence of the current surgical practice, which roughly correlates to the British era from 1800 onwards. From there on, the healthcare system in Sri Lanka expanded drastically. Civil medical departments were set up, missionary hospitals augmented the hospital system, a dispensary system was brought in, and a district hospital ordinance established hospitals in most of the plantation districts from the 1800s. And we actually had our first private hospital in Sri Lanka at the beginning of the 20th century. So the British expanded hospitals very widely. This is the Victoria Memorial Eye Hospital in Colombo from the turn of the century. And in fact, by the end of the British era, Kandy itself boasted over 6 hospitals in one town. Modern surgical education also started around this time. Joseph Sansoni, around the turn of the 19th century, was probably the first Sri Lankan to be trained in Europe, and he was a garrison surgeon at Handala Hospital. The first Sri Lankans who went overseas trained in India afterwards, and medical schools were started in first Jaffna in 1848, followed by Colombo in 1870. the first Sri Lankan to probably get qualified in a specialist area such as surgery was E.F. Kellart, who obtained his MRCS in 1841. He was more famous probably as the author of a zoological treatise on animals of Sri Lanka. P.D. Anthonys was the first Sri Lankan to obtain his fellowship from the College of Edinburgh in 1857. He was also the first president of our first professional body in Sri Lanka, the Ceylon branch of the British Medical Association in 1887. Following this, we also developed professional surgical bodies, the first of which was the Association of Surgeons of Ceylon, started in 1960. This was superseded by the College of Surgeons in Sri Lanka, which now celebrates its 50th anniversary and pays homage to the surgical heritage of Sri Lanka in its 50th anniversary emblem. Thank you very much.
Thank you very much. The only comment I would make is that the two hospitals at Mihintale and Polonnaru are very easy to see now. And many of the Polonnaru instruments, the Alahana Peripene instruments, and the museum there. And it's well worth a look.
Thank you. The next speaker, Mr. Mike McCurdy. Can I invite you to make your presentation? He is the President-elect of the Royal College of Physicians and Surgeons of Glasgow in the United Kingdom. And we are delighted that Mike was able to travel to Sri Lanka and we have his presence here. Over to you, Mike.
Good morning, everyone. Can I say, first of all, what a pleasure it is to be joining you in the Congress of the College of Surgeons of Sri Lanka this morning, virtually in Colombo. My name is Mike McCurdy. I'm the President-elect of the Royal College of Physicians and Surgeons of Glasgow, and I'm going to share with you this morning, over the next 10 minutes or so, some highlights from the history of surgery in Glasgow in the west of Scotland. Our college in Glasgow is the youngest of the 4 surgical colleges in the British Isles. We were formed in 1599 in the last year of the 16th century. The Royal College of Surgeons of England and the Royal College of Surgeons in Ireland are dispute from time to time who is the oldest, but their roots go right back to the 14th and 15th centuries. And our good colleagues of the Royal College of Surgeons of Edinburgh, who you know very well in your own college, were founded at the beginning of the 16th century in 1505. Our foundations and purpose were to bring together the disciplines not only of surgery, but also medicine and pharmacy. And therefore, we like to think of ourselves as the first multidisciplinary college. And we wanted to establish ourselves to improve the medical care of patients in the west of Scotland. And those guiding principles that we first started with are part of our guiding principles today. Our Royal Charter was granted by this gentleman, King James VI of Scotland, in 1599. He's an interesting historical character in his own right. His mother was Mary, Queen of Scots. Her cousin was Queen Elizabeth I of England. As you know, our current Queen is Queen Elizabeth II. And Queen Elizabeth I and her cousin Mary, Queen of Scots, fell out about quite a lot in their lifetimes. And that led to Queen Elizabeth agreeing to the execution of Mary, Queen of Scots, James VI's mother, and she had her head chopped off, as we celebrate in a nursery rhyme here in the British Isles. And James then succeeded his mother's cousin and became the first king of the United Kingdom in what was called the Union of the Crowns in 1603. His Royal Charter set us up to regulate the profession in the west of Scotland, but also gave us a very important charitable mission to provide regular free healthcare to the poor of Glasgow and the surrounding area. The college was founded by this gentleman, Master Peter Lowe. He had followed Hippocrates' dictum that if you want to learn surgery, you have to go to war. And he left Scotland in the 1580s to travel to France and Spain, and there learned the art of surgery as a war surgeon in the armies of Scotland and England at that time, and also of France and Spain. He returned to Glasgow in the 1590s, and he saw that the situation of the medical profession in that area at that time was not good, and he wanted to raise standards. And he is buried in Glasgow in our cathedral when he died there in 1610. Peterloo is also famous for having written this book, The Whole Practice of Surgery. That book was the first textbook of surgery written in English. Until that time, Latin was the language of academic discourse, but he wrote this textbook covering all aspects of surgery that were known at that time and wrote it in English. And we are proud to have a copy of that book in our museum. I want to mention someone who's not a surgeon, but I think is topical in our thinking at the present time. This gentleman, Joseph Black, he was twice president of the college, and in Glasgow he was the professor of anatomy and simultaneously the professor of medicine and the professor of chemistry. And it was his endeavours in chemistry that brought him to great renown in his day. And as we look back, particularly in Glasgow, just having had the COP26 climate change conference here, in which we all talked about our carbon footprints, it was this man, Joseph Black, who discovered the gas carbon dioxide and discovered that it was a product of animal respiration. His other great discovery was of latent heat. And it was this concept which allowed his friend, James Watt, to invent the steam engine. And that, together with the natural resources of West Central Scotland in iron ore and coal and water, which we have plenty of in Glasgow, falling from the sky, it was those resources which then powered the Industrial Revolution of the 19th century. And as we know, it was in that time that great scientific advances began in the field of surgery. Firstly, there was anaesthesia. James Young Simpson, working in Edinburgh, to use anaesthesia, particularly in obstetric anaesthesia, to alleviate pain. But the great surgical pioneer of that century was undoubtedly this man, Joseph Lister. He was born in London, educated there at University College London, having been barred from entry to Oxford or Cambridge because he came from a Quaker family. And shortly after graduation, he became a fellow of the Royal College of Surgeons of England, but he then moved to Edinburgh. In an astute career move, he married the boss's daughter, Agnes Syme, whose father, James Syme, gave his name to the eponymous amputation, Syme's amputation at the ankle. After 5 years in Edinburgh, he travelled to Glasgow, where he took up the chair as the Regius Professor of Surgery, and there began his experiments in what was causing surgical wound infections. So although we had anaesthesia, the commonest outcome from surgical endeavour was infection and subsequent death. He became aware of the experiments of Louis Pasteur in Paris. He began experiments with carbolic acid, using carbolic acid in spray in the operating theatre and also in dressings. In 1866, he outlined his first series of 11 patients who he had treated with carbolic acid dressings. The first of these was an 11-year-old boy, James Greenlees, who in the High Street in Glasgow had his leg run over by a cart, and he sustained a compound fracture of his tibia and fibula. He dressed the wounds. At that time, that would have been a likely fatal injury, and young James Greenlees survived, as did another 10 patients with similar injuries treated with carbolic dressings. And Lister published these in the Lancet in 1867 and became the most notable pioneer of surgery in the 19th century. He returned via Edinburgh to London, where he took up a chair at King's College. He was knighted by the Queen and then ennobled as Lord Lister. And in 1902, still alive after Queen Victoria's death, he advised on the appendicectomy of King Edward VII. The operation was carried out by Sir Francis Treves, but Lister was an advisor on the process and on the antiseptic principles to be followed, and the king survived, probably one of the most famous operations of the 20th century. Lister's principles were picked up by this man, William McEwen, who worked in Glasgow. He was a student when Lister was the Professor of Surgery in the 1860s, and he followed him to taking up the chair as the Regius Professor of Surgery in Glasgow in 1890. He pioneered not so much antiseptic surgery, but aseptic surgery. With that, he began to experiment with sterilizing not the atmosphere of the operating room, but rather everything that was used in it. But Semmelweis had discovered that washing hands was good. It was William McEwen who discovered that washing instruments was good. And he began to boil all surgical instruments before using them. He began to boil cloth drapes and began not just to wash hands, but to wear gloves. And it was his experiments in aseptic surgery which made surgery even safer as the 20th century dawned. He was also the first person ever to operate inside the cranium. He began to localize lesions within the cranium, within the brain, by good clinical skills. And in a very dramatic development, he wanted to operate on a young boy who he thought had an abscess in the frontal lobe. The family refused permission, but when it came to a post-mortem, McEwen was discovered to have been right and that the abscess had been in the frontal lobe as he had thought. Shortly afterwards, another case of a young woman who came with focal epilepsy, and he was able to suggest that she had a lesion in the left lobe, and he operated and removed a benign tumor, a meningioma, and that was the first recorded case of intracranial surgery. I want to mention one other person who was a pioneer of the Victorian era and associated with our college, this gentleman, David Livingstone. He was born in very straitened circumstances in Blantyre, just outside Glasgow. He was self-taught to read and write, to learn Latin, and we gave him his medical degree in 1840 through the Royal College, and he then travelled to Africa as a medical missionary. By repute, he converted one person in all of his years in Africa to Christianity, so he was not much of a missionary, but he was a great explorer. And he travelled, the first European to travel from west to east across the continent of Africa. He was the first European to see Victoria Falls in northern Zimbabwe and name them after Queen Victoria. He looked for the source of the Nile, though never found it, though on that journey he was lost to all European contact for 6 years. And he travelled the Zambezi River. And he is held in very high regard in Malawi, with whom we have a very close relationship through the college and indeed the whole country of Scotland. And in some ways, he was the father of what we would now call global health. And he was a passionate anti-slavery campaigner, an abolitionist, and he had the revolutionary concept that Europeans could work together in a partnership of equals with Africans. Very revolutionary for his time. He died in Africa in 1869, and his body was brought home to Westminster Abbey, where it is buried today. So I'll leave you with that thought, that we had surgical pioneers, but also pioneers in reaching out to other countries. Thank you very much for your attention today, and it's been a pleasure to be with you this morning. And I wish you well for the remainder of your congress.
Thank you, Mr. Mike McCready, for that interesting part of history that you have just shared with us.
The next speaker is Dr. Santosh Abraham. He's the head of the Department of Surgery of Lord's Hospital in Kerala in India. He's been the past president of the Association of Surgeons of India and the director of the Academic Council of the ASI. And out of interest, I've had the privilege of meeting both him and the next speaker, who is Professor Chowdhury. So Dr. Santosh John Abraham.
Introduction, Professor Arivaria. And I'm indeed grateful to the organizers of the annual meet of the Association of the Surgeons of Sri Lanka, the Sri Lankan College of Surgeons, for having invited me to this gathering. A surgeon is a person who possesses the courage and presence of mind, a hand free from perspiration, a good grip of sharp and good instruments, carries his operation to the success and advantage of his patients. I'm indeed privileged to give a concise picture of the history of surgery in India. I take you back to the Vedic age of before Christ, 1500 to 500 years, early Bronze Year and early Iron Age in the history of the Vedic literature, including the Vedas, which composed of the northern Indian subcontinent between the end of urban Hindu Valley civilization and the surgent urbanization which began the central Indo-Gangetic plain. This part of the history should be patronized by India as well as the past undivided Pakistan. And it is from here that we get the first records of ancient surgical science. Shaila Tantra. Shaila means broken arrow or a sharp part of the weapon, and the technique of bringing it together, Tantra, was the first coined term of surgical practice which were found in the Vedic relics of the Indian history. Post-Vedic medicine in India, we had three main pillars of Ayurveda, which is considered as the fifth Veda
Santosh, Santosh, can I disturb you for a minute and ask you to see if you can change your slide to the presentation view?
It is already in the presentation view, sir.
Okay, thank you.
Three main pillars, the Charaka Samhita, the Astanga Sangraha dealt with medicine, Sushrita Samhita dealt with the surgical knowledge, and we have description of cesarean.
Sorry, Santosh, the slides are not moving.
It's not moving?
Yes.
Can I request them to show the slides? I can speak from here then.
Yes, please continue to speak.
Are you on the first slide?
We are seeing the first slide.
So I will. Is this slide visible now?
Yes, yes, yes. That's great. Thank you, Santosh, for understanding.
Okay. So I would go to the Vedic times where the period of Bronze Age, and we had some evidence of surgical things from the northern subcontinent. And this part of the history belongs to both India, the undivided Pakistan, where we have the first treats, which is the Shaila Tantra, which I have already mentioned. Now we come to what we start as the Ayurveda, which is the fifth Veda amongst the four Vedas, out of which Sushrita Samhita, written by the great Sushrita, where the surgical knowledge is spared. We have a description of cesarean section, cataract surgery, and various other operations which even now we perform. The Sushrita Samhita actually describes 60 types of 60 types, and he also had the classification of surgeries into 8 different categories: excision, scarification, puncturing, exploration, extraction, evacuation, and suturing. Mind you, all these things were done about 1,600 years prior to the birth of Christ in the Indus Valley civilization. He undoubtedly is described as the father of plastic surgery. He is also described as father of Indian surgery. There is some controversy of his being named as the father of surgery because Abu al-Hasim of Iraq is also having a reference to that effect. He also is in competition with Hippocrates in being father of medicine, but the chronology of age at which he has practiced medicine is far above that of Hippocrates. So the Indian physicians at those days were belonging to 3 different streams: the Vaidyas, which practiced Ayurveda, the Unanis practiced by the Hakims, and the local practitioners, folk practitioners, which were popular among the masses from the ancient times. Though it is well documented that Apostle Thomas landed in Cranganore in AD 52, it was the exploration of the Europeans was first by Vasco da Gama, who landed up in 1847. Then we had Portuguese invasion, we had Dutch invasion, British invasion, the Danish came, and finally French also colonized India. So the French was the first, in fact, to establish the School of Medicine close to Pondicherry. And following the de jure transfer of the Puducherry to India in 1956, Government of India took over and renamed it Medical College of Pondicherry. For a few years, it bore the name of Dhanvantari Medical College, but in 1964, it is named as the Jawaharlal Nehru Postgraduate Institute of Medical Research and Education. And I'm sure that many of the surgeons in the SAARC countries would have visited this institution, which is considered one of the top institutions of medical education in the country. The Portuguese in 1942 established another school, which was the first modern allopathic school in India. And here the alumni were appointed as chief doctors of Mumbai and some of the small kingdoms in the western part of the country. Post-liberation, it became the Goa Medical College. I'm sure that many of you have visited that. Physicians of colonial India, we will have 3 divisions, out of which the first phase is the experiment which coexisted between the surgeons of Nave India as well as the British who came with the commercial interest. Indians were not eligible at that point of time, and 3 services were put. They are the Bengal Medical Service, the Madras Medical Service, and the Bombay Medical Service. And this essentially served war needs of the Indian soldiers. But unfortunately, the high caste Hindus of India refused to receive the treatment from the Britishers. This made an inferior medical system wherein British chose the Indians as medical assistants and hospital orderlies from 17th century to dispense the high caste Hindus with medicine with their prescription, which they received. The British established the first hospital in Calcutta, which was open to the public, and explored the possibility of Ayurveda. And in 1750, the company established botanical gardens actually to do research on Ayurveda and its combination with modern medicine. The phase 2 is with a game of patronage. The company insisted of formal diplomas from the Superior Medical Service, and the registration of GMC was made compulsory. And this made actually the Indian graduates very difficult to get into the IMS service. Calcutta Medical College was established in 1835 with the Western medicine with teaching in English. Colleges were similarly opened in Bombay and Madras, which were recognized by the Royal College of Surgeons. Another medical college in the same time was set up in Lahore. I'm sure that people would be referring that soon in the history. It was Europeans, Eurasians, and Nave Christians and Parsis which formed the majority of medical students. The native Indian Hindus were elect until 1836 when Pandit Madhusudan Gupta conducted the first human dissection by an Hindu person. This paved the way for a large number of Indian Hindus joining the medical school and getting qualified. It was in the IMS, there was a competitive entrance examination way back in 1855, and this also followed by an interview. The training of the Indian women in medicine started gaining momentum in 1880s with the establishment of the Ducting Fund. The Indian Medical Service was formed in 1897 by amalgamating the superior medical services of the 3 presidencies. So the surgery in India would be brought into colonial British, the Christian missionaries, and the Indian systems. I need to make reference of 3 important medical educational establishments in India. Christian Medical College, Vellore, started with Ida Skyder, which was just a dispensary in 1900, moved to a 40-bedded institution in just 2 years' time, which started the first department of surgery in India. And it was the medical school was opened only for the women, and later on, in 1942, it became a full-fledged medical college offering MBBS graduation to the Indian students. Some of the legends, Ida Scudder, Macpherson, Paul Brand, and Fritchie were internationally renowned surgical names. The first line of Indian surgeons belonged to Dr. H.S. Putt, LBM Joseph and Aswan, all of them were British trained. In 1952, the General Surgery Department hosted the national meeting of the Association of Surgeons of India at Vellore. The second institution in the northern India would be Christian Medical College, Ludhiana, began in 1881 by two sisters, the Greenfield sisters, and later on in 1894, this was the first medical school for women in the whole of Asia. The Department of General Surgery was established in 50s by Dr. Forrest Eggleston, who was a head of the department for a couple of decades, and he had many fests to his credit in starting in India, including the Tumor Board, the Journal Club, and he also was instrumental in starting the Northern Chapter of the Association of Surgeons of India. Last of the three institutions I would like to make mention is the CSI Hospital, Mayur. One, Dr. Pius was the head of the department. Later on, we had Dr. Somerville, who was actually in the third and the seventh expedition to the Everest, having failed, toured India and found this small spot where he first installed the first radium treatment in the whole of the country. And it's a beautiful treatise to read his autobiography, The Knife and Life After Everest, how he spent the whole of his life in the southern tip of India. Multiple standalone units of surgery was there parallelly in the whole of the country. The history of the association was started with this gentleman, Colonel Pandale, who acquired his MBBS from Madras Medical College, moved on to England to get his MRCS LRCP in 1911, joined the IMS and was drafted to the Royal British Army to serve Ethiopia in World War I. Took his FRCS in 1918 and was brought to India to serve in the Air Force Command Hospital at Bangalore. He was the first IMF officer in charge of the Madras Medical College, professor of surgery, worked till 1937. He was superintendent. He was organizing secretary of the Indian Science Congress at Madras in 1927. At that point of time, he thought that it is a good idea to have a surgical organization. And in 1937, when he became the reception committee chairman, he materialized this. And in 1938, birth of Association of Surgeons of India occurred at Mumbai with him as the founder president, who held the position for 2 years. Some of the great names which I have mentioned here were the previous presidents of the association, as the first 5 presidents of the Association of Surgeons of India. The first gathering was just 150 members. Today, the association has grown to have more than 30,000 membership, the second largest professional body of surgeons in the whole of the world. We have postgraduates as members of the association. Apart from this, we do conduct CMEs, skill development programs, conferences at regular intervals. We also provide with indemnity and social security for its members. It's a constantly growing organization. And I'm sure that all of us are proud to be members of the SARC Surgical Care Society as members of the ASI. I'm sure that I have given only a bird's eye view of what is history in the past. Thank you very much, ladies and gentlemen, for a patient listening. Thank you.
Thank you, Dr. Abraham, for that exciting sharing of a vital piece of history that we should really be aware of. And from one great friend of Sri Lanka, we move on to another great friend of Sri Lanka in the way of Professor Abdul Majid Chowdhury, whose company we have the pleasure of. And may I invite Professor Chowdhury to make his presentation. He's a general surgeon and laparoscopic surgeon of Pakistan, and he has been the president of the Pakistan College and a frequent visitor to our country.
Very good morning, ladies and gentlemen, and congratulations not only to the College of Surgeons of Sri Lanka, but the whole nation for such a wonderful Golden Jubilee celebrations. Ladies and gentlemen, I have been asked to talk on history of surgery in my part of the world. You know, India and Pakistan, just listened to Santosh, very wonderful presentation. And India and Pakistan had many things in common, and I think no history of surgery is complete without mentioning of name of Sasharuta, who was the father of surgery in this part of the world. And ladies and gentlemen, just like in Britain, in this part of the world, barbers have been playing active part in the surgical field when British took over and started the development of medical colleges in the subcontinent. As was mentioned earlier, Grant Medical College, Maharashtra was established in 1945, and then after the division of India, King Edward Medical College was established in 1860 in city of Lahore. And of course, Calcutta Medical College, and then in city of Lahore, one of this great philanthropists, Sir Gangaram, he started with the hospital in 1921 in city of Lahore, and then in 1942 he renamed it after his son, Balakram Medical College. And in 1947, after the partition, this was converted to Fatima Jinnah Medical College, which is now a medical university. And in 2015, it was upgraded as Fatima Jinnah Medical University, which is a university for the ladies only. In 1947, King Edward was the only medical college in Pakistan, and 1890 there was a licentiate medical college which was established in Hyderabad, Sindh, which was subsequently elevated to medical college and moved to Karachi and was called as Dow Medical College in 1945, which was affiliated with the Karachi University. Then Liaquat Medical College, Jamshoro, was founded, actually medical school in Civil Hospital 1881, which was awarded the status of medical college in 1945, and in 2001 this was awarded the status of a medical university, the first medical university in Pakistan out of 14. Ladies and gentlemen, then subsequently a National Medical College was established in Multan in 1954, and then in the KPK province near the Afghan border, Lady Reading Hospital was upgraded as a medical college. And some of the names that I would like to mention were Professor Gardesi and Professor Feroz Shah. They were the leading surgeons in that part of the Pakistan. Then Khyber Medical College was established in 1955 and then again raised to the status of the medical university. Till 1974, there were 6 medical colleges and few more opened in Bahawalpur, Ahmedabad, Lahore, Faisalabad, Ladkhana and Rawalpindi. And then in 1990, Aga Khan Trust opened up a university in Karachi, and now there are about 50 medical colleges in the government sector and about 120 colleges in the private sector, which has come up in a big way. Punjab University has been running MD-MS programs in Pakistan, so we have 2 parallel systems of medical education and training in Pakistan. One is the universities, and then the other one was in 1961 saw the launching of the College of Physicians and Surgeons of Pakistan, exactly on the line of British colleges. And now College of Physicians and Surgeons of Pakistan is training in 74 specialities up and down the country. In 1947, at the time of partition, Colonel Barucha was the chief of surgery at King Edward Medical College at the time of creation of Pakistan. And then Professor Amiruddin, a graduate of Glency Medical College, Amritsar, moved to Lahore in 1947, and he was joined by Professor Habibur Rahman, who joined King Edward Medical College. Most of these people, they trained postgraduates till 1970s, and majority of surgeons had their training done in Britain. And these are some of the pioneers of people of Department of Surgery at Liaquat Medical College, Hyderabad, and first Professor Fazil in Karachi. Ladies and gentlemen, I think I will stop here because of time constraints. But now, I think we have gone in a big way in the form of 14 medical universities in Pakistan and College of Physicians, Surgeons. So we have two parallel systems going on at the same time, just like they had it in Britain. But you can have a primary education in the universities like MDMS and FCPS Pakistan. With this, I would like to thank the organizers for organizing such a wonderful conference, and thank you very much for your patient listening. Thank you.
I have the pleasure of thanking all the speakers and the way in which they have in fact put out the challenge which our generation and the subsequent generations have to take up in further improving and developing medical teaching and patient care in this part of the world. Thank you very much, everybody. And we break up for the next session now.
Thank you very much, Professor Arjun Alubihare and Dr. Jayendra Fernando, and all the panelists for that very educative session on surgical history. We move on to the plenary number 4 on Crohn's disease. I would like to invite Professor Kemaldeen and Dr. Amal Priyantha to chair this session. Over to you, sir.
Thank you. Good morning, ladies and gentlemen. Welcome to the 4th plenary of the annual academic sessions of the College of Surgeons of Sri Lanka. This session is on Crohn's disease. The speaker is Professor Neil Mortensen, who is no strange to us, especially those who are practicing colorectal surgery. Professor Neil Mortensen is the Professor of Colorectal Surgery in the University of Medical School, and currently he is the President of the Royal College of Surgeons of England. Over to you, sir. Thank you.
Well, I'll start again. Good morning, everybody. We're just making sure the sound was working. Good morning, everybody. I'm Neil Mortensen. I'm the President of the Royal College of Surgeons of England, and it's a great honour to be making this presentation to the College of Surgeons of Sri Lanka, and I hope you have a very successful meeting. I'm sitting here in our newly opened college building. You can see the picture on the left is the front of the Royal College of Surgeons of England, but behind that, much has been changed and rebuilt. I'm in one of the upstairs rooms, in front of a retained fireplace. We don't have any pictures up yet. We've only just moved in. We look forward to welcoming you to the building one day. So I'm going to talk about Crohn's disease, which I know isn't particularly common in Sri Lanka, but this is an interesting story about how diseases get a name. Should it really have been called Crohn's disease? So back in 1966, I met a patient of Burrell B. Crohn. I didn't ever meet him myself, but I met a patient who'd been looked after by him. Judith presented with 2 years of weight loss and abdominal pain, and at those times there were bare x-rays rather than endoscopy, which showed a lead pipe small intestine. She sought a second opinion from Dr. Crohn, who was visiting London, and she had an operation for removal of the disease. She recovered and put on weight and went through her adolescent growth spurt. Here's the letter written to Judith after she'd recovered by Burrell B. Crohn, offering her a chance to help in his house in New York, 1000 Park Avenue. Crohn died in 1983. And why is it that his name was attached to the disease we now call Crohn's disease? He studied at Columbia, New York, and was a physician at Mount Sinai. And early on, he did research, like many other surgeons and gastroenterologists, on gastroenterostomy for duodenal ulcer. And he presented a paper at the 1916 AGA and there met William Mayo. The next few years, he was interested in pancreatic and biliary secretion. He died at the age of 92, retiring from practice at the age of 91. We now know that the natural history of Crohn's disease starts as some ulceration in the intestine. The inflammation then proceeds to something which is transmural. The mesentery becomes thick. And then eventually we get the late effects of Crohn's disease on the right, where the bowel on this CT scan is thickened and narrowed with a stricture, and there is proximal obstruction. There are some endoscopic pictures of the ulceration and mucosal hypertrophy, which is very typical of small bowel Crohn's disease. And of course, we also know that it tends to fistulate either through to the abdominal wall in this bottom picture or to an adjacent organ, another piece of intestine or bladder. It's interesting to think, though, what it was like for the physicians and surgeons back at the beginning of the 20th century. They didn't know there was something called Crohn's disease. All they saw was either tuberculosis, a chronic granulomatous intestinal condition, or what were called pseudotumors, lumpy parts in the small bowel, which they couldn't really describe as a disease. There was a disease in cattle, however, which had remarkable similarities, Johne's disease, and it causes wasting, much as Crohn's disease does, and John himself suggested it was caused by Mycobacteria paratuberculosis. There were, of course, early descriptions before even Crohn's gave his name to it. Inflammatory bowel diseases were described by Morgani. John Abercrombie in 1780 suggested, in the early 1800s, suggested something similar to Crohn's disease. And in the Pathological Society of London in the mid-1800s, 30 or 40 cases were described, which must have been Crohn's disease. An early description was by the Polish surgeon Leniowski in 1903, and indeed to this day, Crohn's disease is called Leniowski's disease in Poland. Many think that DL, this surgeon at the Western Infirmary in Glasgow, was the first to properly describe Crohn's disease. He called it chronic intestinal enteritis, and a paper was published in the BMJ in 1913. It's said that no one took much notice of this because fellow surgeons were preparing for the war and DL retired to his farm. But interestingly, he describes this: in regard to treatment, these cases which have come under observation have pursued their course uninfluenced by diet or medicine. Apparently, only operation can afford relief, and then only if the disease be limited. 7 out of 9 made a perfect recovery after the operation, and one does not hesitate in resecting large portions of intestine. The second to describe it were Moshkowitz and Walensky. They worked at Mount Sinai and Beth Israel hospitals in New York. This was back in 1923, and their early description was completely ignored. We get now to the real hero of the piece, the unsung hero, the surgeon who actually described it, but whose name has never been given to what we now call Crohn's disease. A.A. Berg was a surgeon at Mount Sinai in New York. He worked on the wonderfully called Wimpfheim Award for the surgical treatment of diseases of the stomach and intestine. And as was the case at that time, duodenal ulcer was a really serious problem, and he did many gastroenterostomy operations for DU, but was persuaded by Crohn and Lewison in the same hospital to adopt partial gastrectomy. He, in the late 20s, made observations of 14 patients. Recognizing the distinct features of Crohn's disease, he refused his place as first author or to be cited, giving that pleasure or honor to his junior colleague, Ginsberg. He insisted that Crohn, Ginsberg, and Oppenheimer be cited in alphabetical order. Berg's original operation was a staged procedure First of all, excluding the ileocolic disease with an ileotransverse anastomosis, a bypass, and then when all had settled, the subsequent resection of the diseased bowel, very safe. This is a picture of it. The end of the ileum was uncoupled, brought out as a stoma, and the proximal ileum plugged into the transverse colon, and then the disease part removed at a later date. So, three famous names. Crohn was a physician gastroenterologist, Ginsberg, the surgeon who had assisted A.A. Berg, Oppenheimer was the surgical pathologist. And here's a rare early picture of them, Oppenheimer on the left, Crohn in the middle, and Leon Ginsberg on the right. The first paper was presented by Ginsberg at the AGA, the American Gastroenterology Association in Atlantic City in 1932. Shortly afterwards, Crohn presented at the American Medical Association in New Orleans in May 1932, again, some 11 days later. The discussion suggested that terminal ileitis was rather a gloomy term and that it would be better called regional ileitis, and that was the name that was adopted. So here's the first paper in JAMA in 1932, Regional Ileitis, a pathological and clinical entity. The second paper was published a little later, so it came in publication order in the Annals of Surgery. This was by Ginsberg and Oppenheimer. They also described exactly the same cases, and in a footnote, they mentioned that the section on localized ileitis represents a joint study with Dr. Crohn. So how was it that Crohn's name became associated with Crohn's disease? Well, he was an assiduous data collector. He recorded in a meticulous way. He wrote often about it. And with extensive speaking at national and international meetings, he became the person associated with this emerging disease. Leon Ginsberg, the surgeon on the paper and the pupil of Berg, wrote, "There's no doubt that Crohn put regional ileitis on the map, so to speak. He popularized, publicized, and spent much time and travel on lecturing and spreading knowledge about it. His extensive collection of stats gathered from his own practice helped clarify matters in the early years." So Ginsberg wasn't bitter in any way that Crohn's became the person associated with Crohn's disease, but it was Brian Brooke, a surgeon in London, professor at St. George's, who had a big inflammatory bowel disease practice, who became friends with Crohn and wrote often about regional ileitis in the Lancet. And it was Brian Brooke who began to call it Crohn's disease. Brooke, of course, known for the Brooke ileostomy, the first ileostomy which was spouted, and he founded the first ileostomy association in the UK too. Now, although at this stage small bowel Crohn's disease had been recognized, it was a while before colonic Crohn's disease became an established disease in its own right. And although granulomatous disease of the colitis had been described and seemed to be different from ulcerative colitis, nobody was sure. In 1952, Sam Wells described a segmental colitis, which was probably a form of Crohn's disease, but it was Basil Mawson, the famous histopathologist at St. Mark's Hospital, and Lynn Lockhart Mummery, who first described colonic Crohn's disease properly and distinguished it from ulcerative colitis in this paper in Gut in 1960. So what was surgery like then in New York? Here we are, here's ether, here is all the old theatre gear in this beautiful painting from the 1930s. The Mount Sinai operation, as it became called for Crohn's disease, was a simple ileocolostomy bypass with exclusion and no resection, as you've already heard. It was often observed, interestingly, that the disease that had been excluded seemed to heal, and nobody knew why. Garlock and Crohn in 1945 described 164 patients. None died after bypass surgery, but many died after 1 or 2 stage resections. Surgeons and physicians were scared to primarily resect the disease. Now, this is an interesting historical story too. June the 6th, 1944, Dwight Eisenhower leads the landing on the beaches on D-Day for the beginning of the war in Europe and the end of the Second World War altogether. 12 years later, Eisenhower, as now President of the United States of America, had emergency surgery for obstructing regional enteritis at the Walter Reed Hospital. He was a smoker. He'd had a previous myocardial infarction. He was on anticoagulants. And as you might expect, his surgeons were terrified that something bad might go wrong. How about that as pressure on a surgeon? You didn't want anything bad to happen if you were operating on the President of the United States. So what did they do? They did an ileocolic bypass. So bypass has been an important part of the evolution of surgery for Crohn's disease. Bypass procedures were then followed by radical resection of bowel and lymph nodes, followed again by more limited resection, and as we'll hear, more minimalist resections and strictureplasty. At one time, it was thought that you needed to remove all the affected lymph nodes. They might have some sort of as yet undiscovered infective agent in them. And the only way to get rid of the disease was to widely resect it. Here is a couple of famous artistic pictures of the martyrdom of Saint Erasmus, who, as some of you may have heard, was martyred by the removal of all of his intestine. And indeed, with the radical treatment of Crohn's disease, that happened to many patients too. I was a medical student at the General Hospital Birmingham, much after it looked like this, I have to say. And there was much treatment of IBD and early colorectal cancer there, particularly carried out by this extraordinary character, John Alexander Williams, who was the person who encouraged me to do intestinal surgery. He was a larger-than-life, charismatic character, and when told by one professor of surgery at a meeting in the UK that the only way to treat Crohn's disease properly was to widely excise it, he said, well, that means that the only successful operation for Crohn's disease should be the resection of everything between the mouth and the anus with an oro-anal anastomosis. And he said the only successful surgeons or practitioners who'd had this surgery were professors of surgery themselves, in other words, talking rubbish. As I mentioned at the beginning, we now know the natural history of Crohn's disease. We know better how to treat it. But of course, this has all been learnt by evolution, by careful critical analysis of outcomes over the years. And now the philosophy of surgical management is not wide resection, because we understand that the disease is incurable. It has a potential for pan-intestinal involvement, and surgery, we have to be humble and admit it, only overcomes the complications. John Alexander Williams was very famous for writing about GI diseases, and he particularly used this aphorism for the surgery for obstruction in Crohn's disease. One episode of obstruction is a warning, 2 episodes are an indication for surgery, and 3 episodes of obstruction are an indictment of medical surgical management because they should have had the surgery on the previous occasion. These patients experience the classic symptoms of food fear, weight loss, griping pains, and time off work. John Alexander Williams also popularized the bicycle tire test, which I've used many times in surgery. Its modern version, you can use carbon dioxide from the laparoscopic stack, use a nasogastric tube or a stoma or a small hole made in the intestine, distend the small intestine, put it underwater and look for bubbles. The bicycle tire test, really good test in patients who've had extensive adhesiolysis. Now here's another major figure from the world of Crohn's disease surgery. Vic Fazio, who was on the staff at the Cleveland Clinic, of course, for many years, died in 2015, same year as John Alexander Williams. He showed that there was no point widely excising the bowel because it didn't make any difference to outcomes, even if there was microscopic disease at the margins. And this was another signal paper encouraging us to do minimalist rather than maximalist surgery. He described this helpful tip of assessing the proximal margin of resection by feeling the thickness of the mesentery. And when it becomes thin and very pliable, that's the point at which the bowel inside is also normal. He taught us some important lessons too. He emphasized that the biology of adhesion formation took 3 to 6 months, and that if you were in a real tight spot, you should leave the scene of the laparotomy, not do any adhesiolysis, but wait for 3 months or so until the adhesions became soft, the so-called safe zone for adhesion dissection. And many of us have used that in repeat surgery in patients with inflammatory bowel disease over the years. Wait for the safe zone, don't go too soon, or you'll cause trouble. Now, another important figure in all this is Sidney Truelove, who I was privileged to work with in Oxford. He'd by then retired, but he was still a major figure. And as you'll know, he was the person who came up with the Truelove criteria, the gastroenterologist who pioneered the management of ulcerative colitis. And the Truelove criteria describe the severity of the disease. But he obviously saw many patients with Crohn's disease, and he first proposed a defunctioning ileostomy for perianal Crohn's disease, another minimalist operation to bypass rather than resect. This, he saw, was an important way of stabilizing the disease as a bridge to proctocolectomy. And here, in a paper by Catherine Edwards in 2018, patients with dysfunction for severe perianal Crohn's disease, 15 went into remission, but sadly, only 2 were ever reversed with satisfactory function. But at least psychologically, it helped patients get over the acute episode and get their minds around having a proctocolectomy, often a very difficult sell. Now, I replaced in Oxford this extraordinary man, Emmanuel Lee, who is a great writer and painter and drawer. He had read about the reports of the use of strictureplasty for tuberculous strictures. And he thought, well, why don't we use those for Crohn's disease too? And so Lee and Papianou first described strictureplasty for Crohn's disease. And here are some of Emmanuel Lee's early drawings. Strictureplasty, he thought, was part of a package deal. Mini resections and strictureplasty used sensibly together were there to preserve as much bowel as possible. Here is the typical sacculation appearance of small bowel Crohn's disease with dilated segments in between. And Emmanuel Lee shows here effectively different kinds of strictureplasty side to side, or more like a Heineken Michelix that we use in a pyloroplasty, ways of overcoming the obstruction without resecting the disease. A clever way of assessing the small intestine too was with a balloon, which could be blown up and would obstruct at the sites of the Crohn's disease. The important feature here being that if you left a stricture downstream of disease which you treated upstream, you'd have an anastomosis or a strictureplasty threatened by obstruction downstream and more likely to leak. So balloon characterization of the small bowel strictures was really important, shown here, and that the sites of impaction of the balloon were marked, and then the balloon let down and reinflated, and the rest of the intestine characterized. Here's a better picture of the use of strictureplasty, a vertical incision and a horizontal suture, marked with a clip so they could be seen and reviewed on abdominal CT. And interestingly, much as Berg had observed way back, at some sites where strictureplasty has been carried out, the disease seems to completely regress, and we don't know why. These are some figures from Emmanuel Lee's early cases, with patients putting on weight after their surgery. And they published their report after a number of years in the Annals of the Royal College of Surgeons of England. That's a great journal, of course, because I'm president of the Royal College of Surgeons of England, but not one that was very widely read. And not a lot of people knew straight away that Lee had described strictureplasty in the first place. We have delayed reporting it widely in spite of the marked benefit obtained. Our particular worry was that the technique contravenes a widely held surgical view that it's hazardous to anastomose bowel in which Crohn's inflammation is active. A really, really iconoclastic move in a disease which otherwise is so difficult to manage, and he played such an important part in bowel preservation in patients with small bowel Crohn's disease. But of course, some of these other characters, at the top, Vic Fazio, who I've already mentioned, and John Alexander Williams on the left, traveled the world talking about strictureplasty, and everybody thought it was them. But it was, of course, Emmanuel or Manny Lee who first described it. John Alexander Williams, as I've said, was at the General Hospital, Birmingham. He traveled the world. He talked about the 10 Commandments, bringing down the truth from the mountain on how to manage Crohn's disease. Vic Fazio, Cleveland Clinic, traveled the world too. He strictureplasted everything that moved. International reputation. And another surgeon, my friend Michelassi, Fabrizio Michelassi at the Columbia University Hospital in New York. He has traveled the world too, doing an operation where essentially you can halve the small intestine with multiple strictures, put it side to side, and make a massive extreme strictureplasty, rather like this, which we've done in Oxford a few times, in very, very serious cases where there's no alternative but otherwise resection. And now, of course, this can all be done laparoscopically. These strictureplasties can be done externally. And I just wanted to pay tribute to a moment to Sir Miles Irvine, who's actually now living outside Oxford. He used to work in Manchester. He coined the term intestinal failure and was a pioneer in allowing patients to be at home on parenteral nutrition. But what's interesting is that for many patients, the intestinal failure in their Crohn's disease was often caused not by the Crohn's disease itself, but by repeated resections, often unplanned operations, resulting in shorter and shorter lengths of small bowel, so that eventually the patient couldn't nourish themselves. So with a combination of minimalist surgery and with now proper management of intestinal failure with parenteral nutrition, we can make a big difference surgically to patients with Crohn's disease. But of course, we still can't cure them. We're learning more about genetic susceptibility. We're learning more and more about gut flora. We are appreciating environmental factors in the causes of Crohn's disease, for example, unpasteurized milk. And we're learning more about the host immune response. But we still don't really know what causes Crohn's disease. Today's treatment, of course, includes lots of medications, the immunomodulators and corticosteroids, and now the new biologics, like infliximab, which are making a fantastic difference to the quality of life of many of our patients with Crohn's disease. And surgery is kept not necessarily as a last resort, but only when medical treatment has failed. But it's important that that is done at the right time before patients become thin and wasted and deconditioned for surgery. It's important that patients are managed jointly by a physician and a surgeon. So, 100 years of surgery for Crohn's disease, its early recognition, early bypass surgery, then excisional surgery, at first aggressive and then latterly conservative, surgery plus immunomodulators. We've gone through the experience with strictureplasty now, and we know it's safe. The latest biologics are very effective. Interestingly, in some patients who have such extensive disease that the only alternative is small bowel transplantation, the disease does not seem to recur. And some have suggested that medical treatment may become so effective that surgical intervention won't be needed anymore. I still think that's a way off. But finally, let's just remember the principal people involved in Crohn's disease. Should it really have been called Crohn's disease? Burrell B. Crohn was lucky. He came first in the alphabet, but he did work really hard to have the disease recognized. Berg was a shy retiring surgeon who gave the opportunity to his junior colleague to have his name on the first papers, Crohn, Ginsberg, and Oppenheimer, and then it became Crohn's disease. So it's been a great pleasure talking to you all. I hope you have a great conference. And as I say, I look forward to welcoming you to our new Royal College of Surgeons of England building in Lincoln's Inn Fields in London in due course. Goodbye for now.
Neil, thank you very much for the great overview of the past to the present of Crohn's disease. Is he still there with us? Are you still there with us, Neil? All right. So without much more ado, I'll call this plenary session closed. There is no questions anyway, so thank you.
Thank you very much, Professor Kemaldeen and Dr. Amal Priyantha. So now we take a small break for the morning tea, and we'll be starting the symposium number 2 on limb trauma in Hall A, and the urology symposium in Hall B, sharp at 10:45. Please be back by then and enjoy your tea break. Thank you.